Okay, this one. And this is for, okay. Okay, okay.
Hello, hello.
Hello.
Yes, yes.
Okay, oh, can you hear me?
We are, yeah. We are in auditorium and we are able to see the eardrum and view of tympanic membrane perforation. And Dr. Daniel Marcioni, he is professor in head department, University of Modena, Italy, and at present, live surgery for endoscopic otosurgery. And he is, I just give a brief introduction to all. He is a ENT director, Arizona Hospitalier University Integra, Verona, and chair postgraduate school of otolaryngology, Verona University,
Ecco,
consultant in new hospital, Vesoli, MO, collaborator, otolaryngologist of ENT clinics of Moderna Hospital from 2006 to 2014, and he is external collaborator of Evangelio Valdesi Hospital in Torino 2001 to 2005, external collaborator of the ENT clinic Moderna Hospital 2000 to 2006. We welcome Dr. Daniel Marcioni. Please, we are here in the auditorium, able to communicate with you, and I will request the moderator, Archil,
thank you very
and Dr.
much.
Yes,
Thank you very
please.
much. We are starting to do the injection of the external auditory canal. You can see it's, I think, adrenaline solution, I don't know, with lidocaine, and this is really important because when you are doing endoscopic ear surgery, you have to do one hand technique, and with one hand technique you have to manage the bleeding. So it's really important to perform a good injection to try to avoid the bleeding. You can see the perforation is here. Can we have also the cotton balls with adrenaline solution? Cotton balls? Okay.
Professor Daniel, I am Dr. Vikas.
Yes?
Sorry for the interruption. I just want to ask, what is the OT setup for this surgery? What is the position of patient and surgeon's position? What is the position of
Okay, so
monitor?
I'm standing in front of the patient. I don't know if you are able to see the external camera. And so I'm standing in front of the patient. And in front of me there is also the camera. Do you have another cotton ball? And the position of the bed, it's better to have the bed just a little bit higher with respect to this today. So we can we push the bed higher? And of course we have to hold the endoscope with one hand. I don't know if you are able to see my hands, probably. And if you can see here, I can hold this endoscope with one hand, and with the right hand you can move the instruments. Do we have a scissor, a small scissor for the hand? And we have to wait just a little bit after the injection. Oh, this is curved anyway. And we have to cut the air. Okay, thank you. Okay. This is a perforation, so the plan is to do underlay technique. We have to check the cavity, and we have to decide regarding the graft if using a cartilage or a fascia, depending of the condition of the tympanic cavity. Because if you have a failure of the Eustachian tube, it's better to use a cartilage. If you have instead a normal mucosa with the normal ventilation pathway, you can use also fascia, depends. We have a crocodile to remove them.
Crocodile.
And then
Professor, tell what local anesthetic you use for the infiltration.
the local anesthesia, I'm using the local anesthesia that you are using here now, but in our department we are using adrenaline and mepivacaine.
Okay.
So we can remove this. Okay. We can remove also this. And do you have a sickle knife? And this is for you. So now we have to refresh the edge of the perforation. You can see here, just a little bit. Where is it?
Under GL, sir.
Okay, I think that this is sufficient. Suction and cotton balls. Yeah.
Dr. Daniel, what is your plan? Are you planning for anterior-based flap or superior-based flap in this?
In this case, we have to do an incision like this, and we have to
Okay.
elevate the flap. Do we have another cotton ball? Another cotton ball? A larger one. So this is all with the adrenaline, this, and another one. We have to pack just a little bit. And after, if you are able to have a small tip monopolar, we can perform incision also with the monopolar, but I don't know if, let me check the monopolar here. Oh, this is too big. Look, this is too big. So we have also a smaller one. A tip, if you have. Oh, this is bipolar. And okay. So now we can do with the ram knife the incision, because if you have in our department, of course, nowadays we are using a small monopolar in a low power in order to do the incision, in order to control the bleeding, because another important aspect is the bleeding during the arising the flap. Okay, we can remove the cotonoid. Crocodile.
Professor Daniel, do you recommend endoscope holders for these cases?
No, we don't use endoscopic holder. We are using one hand technique. The holder can help you because you can use two hands instead with one hand. One hand technique, of course, is more difficult, but one hand technique is more dynamic. You can move the endoscope as you please, and you can check the cavity, and so it's suction.
Sir, what is the size of endoscope you are using?
This is 3.
3 mm. Okay.
And length, sir? What is the length?
The length is 15 centimeter. Round knife.
Okay.
So we can start the incision from here. And also over there. Do you have also the bigger one? And so we can start the elevations of the flap. Cotton balls, and you can see that now we can see the bleeding, and we have to put a cotton ball in the middle. Suction, please. Possible to have less suction power, because this is really powerful. Please, can you remove this? Are you a big cotton balls? Big cotton. And the suction should be less big. Suction. So now you can see that the cotton balls, it's really important to pull the flap. You can see you have put here, and after you have to clean the border until you can see the bone. Can you see the bone now? Now we need a ram knife, and after we have to go more close, and we have to put the focus. And you can see that we are able to see here the chorda and the annulus. And we are elevating the flap. This is the pedial tendon. Granulation tissue. And this is the malleus is here. And the chorda is over there. So now we need the coccyx or caps forces. You have to pull a little bit the flap. Do you have a smaller one of this?
A smaller crocodile. A smaller of this. Quando vuole mi fa vedere quello quanto è grande che non è questo anche molto grande.
Okay, so now we can remove the cotton balls, and you can see the flap. Sickle knife. You have to pull anteriorly the flap. Now, if you want, we are already done, but in this situation, you can see this is the stapes here, and the incus. You can check the movement. The stapes is good, and this is the round window. And if I put this, you can see the movement of the round window. So it means that it's okay. Suction, please. and the cotton balls, because we have to close. Can we reduce the suction, or you give me a smaller, because this is too heavy for this surgery.
Cotton ball.
So now we can check the anatomy. Look, now we can see the border. Can you see there is a small bleeding over there? So if you have a small bipolar, we can manage.
The one you
Just to show you the management of the bleeding, you can see here. And just in the border of the skin, you can use the bipolar in order to manage the bleeding.
devono montare.
Now we are waiting just a little bit the bipolar.
Oh, that's the worker. There is a.
If I have, fai un piccolo bip,
Ok.
just a small bip,
Just a
bip,
little bit.
bip, 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 oh, bip, bip,
Treasury.
bip, 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 okay, bip, okay, bip, right, bip, 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 okay, suction. So this is just to manage the bleeding in the border, especially when you have a cholesterol or something like this, is very important. And you can see that now there is less bleeding all around here. Now we are using the cottonoid to scraping here in the handle of the malleus. Can you see now more close? Okay. We can put also the cottonoid here and the scraping in a soft way, of course. And you can see now better the malleus, the cochleariform process that is here, the isthmus that over there, the incudostapedial joint. Look here, there is the anterior crura over there.
Professor Daniel, how you manage the medialized handle of malleus?
Sorry? L'ho detto, ragazzi? Cottonoid. Give me to remove the cotton balls. Another cotton balls, please. You can see now the situation. We have to pull.
Professor Daniel, how you manage medialized handle of malleus when you are planning for the underlay?
In this case, I want to remove the eardrum from the malleus because the perforation is anterior. So in order to have a good, this is too big, this one, suction. And
Can we cut the lower part of malleus in medialized malleus cases?
This is the malleus. Of course, this
Yeah,
is
look,
the
can
pulsac
we-
space. Pulsac space is here. The short process is here. Long process is here. And this is the umbus. So we have to detach from the umbus. You can see that you are able to see the perichondrial layer here and periosteal layer. This is your plan. No, the malleus is not so medial. It's just a little bit, but it's not a problem. Non ho capito.
Nel caso in cui fosse medializzato il martello.
In the
farebbe
case
qualcosa di
with a medial condition, medialization of the malleus, you have, of course, maintaining, you can try to remove all the adhesion and try to see if it's possible to have a normal position. If it is not possible, you have to leave in this way, of course. Suction, please. Well, it's not. No, it doesn't work. I don't know why. Okay, here now we can see the fibers of the umbus. We have cotton balls. Cotton ball. And suction. Do you have a small crocodile? This is all the mucus under the malleus, and now we are. You can. This is a technique with the gloving of the malleus, of course. And it's really useful, especially in cholecystoma crocodile.
crocodile.
Not so small, but okay. 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 Now we can see a sickle knife. We can see all the flaps. And if you want, we can check also the anatomy of the tympanic cavity. Crocodile. And now we have to cut. Scissor. Okay. Okay, this is the fibrous layer, so we can cut like this. Sickle knife. Now we can check. You can see this is all the flap. Now we pull the flap anteriorly with respect the external auditory canal, like this, and we can check the condition of the Eustachian tube. Now we can see here, this is the Eustachian tube. Looks fine, I think. This is the round window niche, the fustis, the funiculus, the subcochlear canalicoli, and ma forse anche con una fascia, cosa dite?
Vedere cartilagine però.
Cartilagine, poi cade.
Bellissimo, per cosa dice cartilagine?
Suction. We can do a cartilage graft or a fascia graft, depend of the situation. In this case, we can do also a cartilage graft. You can see here the movement of the round window. That is good. Look. Look at the subcochlear canalicoli, that is really deep here. And you can see that the advantages of one hand, we have a cotonoid, is that is a dynamic technique, because if I want to see the Eustachian tube, I can go like this. If I want to see the sinus tympani, I have to go like this. So it's different. You can see the facial nerve over there, and the isthmus is here, so suction. Do you have a curve dissector that I have to measure the...
Thomas sinus tympani dissector. But shorter, yes.
If you want, we can check also with the 45-degree endoscope. Do we have a 45-degree?
Yeah.
Okay, we can change the endoscope with the 45 just to show you
2.7 and 4 mm. Which one you want?
2.7.
2.7.
C'è di cintura curva se vuoi.
Com'è?
Di cintura curva.
Sì. Now with this we can check
2.7.
the length of the graft. This is the anterior part of the perforation. Do you have the longer one of this? Va bene, perché serve per misurare. Ok, allora possiamo dire che è 1 e 1. 1 e 1. Suction and cotton balls. So now the best way is a composite graft. That is mean to put a cartilage and a perichondrium layer. Now we can put a cotton balls and we can recognize the cavity with the 45 degree.
Sir,
Yes?
Daniel, can we see the ventilation pathways
Yes.
if they are blocked or open?
Yes. Now we can see with the 45, because in order to see this, we have to use a 45-degree endoscope. So now I'm putting a 45 degree. The view is not so good. Let me check. Okay, we can check now. Do we have to remove the cotonoid? Now I'm using a 45 degree. And look, the view is completely different, and we can check the isthmus. You can see here, this is the anterior isthmus that is good. You can see here that there is a good space between the malleus and the incus, and also the posterior aspect is good. You can see the opening with the facial nerve and the lateral semicircular canal. We can check also the sinus tympani, that is good, is over there. And also, do you have the curve dissector, the smaller one? Thomasen. And you can see, this is the tensor fold here. This one, that is a complete, and instead this is the anterior isthmus. The cochleariform process is here. This is the tendon of the malleus, you can see. And also you can see here the incus and the stapes. So everything is going well, honestly, in these patients. Now we can reconstruct. We can put at 0 degree now. We can reconstruct with the composite graft with the cartilage. Cotton balls. Let me check just a little bit here. Sickle knife. Prima riposizione. Sickle knife. Okay, let me check. Okay, this is our flap. Suction. And cotton balls.
So if we can summarize the surgical procedure done till now, I would like to highlight two very important factors here. That the denudation of the epithelium from the handle is a very important step to prevent any inadvertent iatrogenic cholesteatomas in future. And as we all have observed that the ossicular chain has been minimally touched to prevent any dislocations and other things. So this is for our early learners and beginners, that while doing surgery, be very gentle with the middle structures, as they are very prone to get dislocated easily. And hemostasis, as sir is doing in the one-handed technique, hemostasis is a very important step to be managed. Continuously, he is using cottonoids, probably with adrenaline-soaked cottonoids, to prevent those hemorrhages.
Yes, this is not an easy technique. You have to manage in a different way. It's not like with two hands. When you are using two hands, you are always like this, really like the animals. Here you have to do really soft. Every movement is really soft on the ossiculary chain, on the external auditory canal, to move the cottonoid. You can see that I can put like this. I put just in a gently way like this, and it's totally different technique, and it's difficult. It's a difficult technique, and you are not able to manage like microscopically. You need a learning curve. To do a degloving of the malleus, you have to be careful. You are looking for a right plane, that is a subperiosteal layer. If you are in the subperiosteal layer, you are able to degloving the malleus until the umbus. In the umbus there is no skin, there is just fibrous layer. You have to cut really close to the malleus in order to avoid, of course, iatrogen cholesteatoma, because if you leave the skin on the malleus, it's not good. Now we are collecting a cartilage.
Can we have
Mi puoi togliere gli occhiali? Che non...
So why are you using a cartilage here? Any particular reasons?
Yes, because in this case the perforation is not so small, it's a little bit big, so I want to do a total repair with the cartilage, and I think that is in this case the best way. But you can use also fascia. It's not wrong to use fascia also in this case. It's just attitude of the surgeon, honestly, and because I think that the Eustachian tube is working. It's not a problem of the Eustachian tube in this case. Do you have large cotton balls?
Stavo per infiltrazione.
The cartilage in this case is not possible to use just single piece. You have to use a composite graft. That is mean the first layer is a cartilage, and the second layer is the perichondrium between the cartilage and the reconstruction. Gauze? Do you have a gauze? Okay. Do you have something?
Professor, do you always go for the Eustachian tube function test before performing any ear surgery like this?
Function test, Eustachian tube, yes, but honestly, attention, no, bipolar. Honestly, it's not so easy to understand if I'm not able to see the light.
Light, technically.
Can we manage the lights because
And
from
can I-
here, maybe from here, you know?
Can I have the larger section?
Endoscope for me.
I will hold this.
No. So it's better to harvest a large piece. Okay. Do you have something, a forceps? Okay. No. It's always important to take a large piece of the cartilage. Okay. Ok, mi dai 2 punti e... Can we wash the... And now I need the table. I need the table to... Can I have something to... I go...
Dalle lui.
Eh?
Dalle lui le cartilagini. Sorry. Can you bring the cartilage now? I think it's better on the table.
Better that I'm working on the table, so you have to turn just a little bit, please. And if I can the light, okay, thank you. And also this one, let me check. This one, and this is two. Okay, perfect. And can I have something to work? So now we have to remove in one side the perichondrium. Can I have something? Okay, like this. And do you have the round knife?
Yes.
And a gauze. And a gauze. Dry goes. Dry.
You can stand here.
Dry. And after, you can see that I did a measurement with this. So I have now, okay. Now I have to remove okay, I'm removing in one part of the cartilage.
So I believe if someone holds the endoscope, that can give us a better picture of what you are trying to do here, sir.
Okay, if somebody can hold, you can see that I'm removing in one side the perichondrium, because I'm using both the perichondrium and the cartilage. Do you have a knife?
Can we see the endoscopic picture?
Please take the endoscopic pictures for the display.
Do you have the endoscopic picture? So you can see now, this is my graft. My graft, I have to remove just a small part of the graft. In order to recreate the membrane. Okay, so we can do the measurement. This is more than one, and this is one. So I want to remove just a little bit here. Okay, so now probably here we are. This is just a little bit more one, and this is one. So we can do something like a groove for the malleus. This is very important to. Do you have to press?
Yes, sir.
We need to press this perichondrial layer, and can we press now? If you have the press, or I can do like this. Oh, this is great. So this, we can press the perichondrium layer like this. Okay. We can use also a gauze in order to have to get dry perichondrial layer, and we can put here. And we can press again because it's not so dry again. No? Now it's a little bit better. Okay, and now we have to do a groove here for the malleus.
So sir is creating a groove in the cartilage harvested to accommodate the handle.
Yes. Okay, so now we have just to press again this one.
Lui è molto bravo a seccarla,
Chi lui?
il nurse.
Ah, I know that your nurse is so clever to
Yes, you are very
drive
good at drying the patient.
more than me, and so I want him to help me because please. Okay, so now we have two layers. We have the cartilage layer, mi dai gli occhiali? And the perichondrium layer. The first layer is the cartilage. Can I have the crocodile? Any suction, please? A crocodile? We have to remove all the cottonoid. A sickle knife. Okay, can you give me the cartilage? Just give me the crocodile. The crocodile. And the cartilage here. So we are doing the first layer. You can see the incision is here. So we have to pull in this way. Sickle knife. And always we have to pull in this way. We have to check here the under situation in order to put this over the malleus and turn like this. And do you have the curve dissector? And this is the first layer. The smaller. Oh, I need anti-fouling. Okay. And after you can see that this is my flap. And I have to decide how to pull I want to pull in this way in order to cover the defect here. And now over here I put the perichondrium. A sickle knife. Again, the perichondrium you have to manage like this. You have to control the most anterior part. And you have to pull between the cartilage and after you have to check okay, this is good. The curve dissector, please. And you can see that now we have to see that this is the composite graft. This means that you have to pull and performing with the cartilage and with the perichondrial layer in order to be sure to have a good contact between the eardrum and the graft. Now it's good?
Sir, by using a composite graft here, do we expect some conductive hearing loss with this patient?
No, it's totally normal like in a normal graft.
So one more question I have, sir. Have you ever experienced thermal injuries because of endoscopes?
Any experience, sorry?
Have you ever experienced thermal injuries to middle ear mucosa or other structures because of the light from the endoscopes?
Yes, yes, you have to use a really low power of the light in order to avoid problems. This is really important. And look, we can check really close and everything is going well. So you have to put your come si dice?
Cosa?
La luce.
Light
sources in a low power.
50%.
50%, not too much. Because if too much, you can have you can burn the tissue. Do you have a spongostan, the gel foam? Okay, so this is the final view, and you can see that we did a composite graft in order to. This is good for anterior perforation because the problem that if you put a fascia, sometimes the graft fall down. So you have a failure of the graft. Instead, with a composite graft, you can have a more stable graft, especially anteriorly. And after, you have to put also the gel foam in order to create the right adhesion.
Recommend putting gel foam in the middle ear if you are using template fascia?
In this case, no, because if you're using a composite graft, the malleus can support the cartilage and...
Perché se usi la fascia?
Non ho capito.
Se usi la
No,
fascia,
ma ha
metti il
detto...
gel foam in cassa, se usi la fascia.
If I'm using a fascia, of course, yes. If I'm using the fascia, you have to put in the tympanic cavity the gel foam Instead, if you are using this technique over the malleus can support the graft.
Hello. Hello, Professor McGrany.
Yes.
Yeah. How far is the issue of post-operative tinnitus in this case? Because we are using concentrated adrenaline in these cases. We have observed in few of the patients that they do have a post-operative tinnitus issue.
Dato che è sotto l'adrenalina e la lidocaina, hai mai osservato dei tinnitus?
I didn't observe any tinnitus. I observed the tinnitus if you manage in not a good way the ossicular chain. If you do like this on the malleus, is not good. You saw, I put a cottonoid and in a gently way push like this, really calm, really gently, just in order to avoid the manipulations of the ossicular chain. That this is the most important aspect of this technique, because if you use the one-hand technique in a wrong way, of course you can have some problem with the ossicular chain. So, but tinnitus for adrenalinic solution, if you put just outside the tympanic cavity, not inside, I never see tinnitus.
This case, exactly what was the size of the cartilage graft? 8 millimeter by 10, or it is less than that?
So the size of the graft is really important to have an instrument for the measurement of the graft. I put, can you give me the Thomas and Long? I use today, I'm using this. You can see this is the Thomas and I measure like this, and depending of the dimension of the eardrum, I decided the length of my graft.
Yes.
Okay, so now we have finished here. If you have other question, please. I don't know, the second case probably is open approach. It's a canal wall down procedure, I think. But I don't remember if it's today, it's tomorrow.
Sir, do you think the dimension of that canal is also important while doing the surgeries? I mean, sometimes there is a narrow canal and wider canal, especially for the new learners. The selection of case is important.
Yes. So the narrow canal, you need a small endoscope, because if you are using a 4 millimeter endoscope, the canal is quite always narrow, because the space between the endoscope and the instrument is smaller. The first rule is using a 3 millimeter endoscope. Of course, if you have a really small canal, or if you have exostosis, huge exostosis, obliterate the canal, honestly, you can do endoscopically, but it's so boring. You have to cut retroauricular incision, drill, and in order to enlarge the canal, and after, if you want, you can use the endoscope or the microscope. You have to select the patients, of course. You need a normal canal, traditional canal, or large canal, and the using of the endoscope 3 millimeter, not 4.
Thank you. Thank you.
Professor Daniel, do you use some other material in addition to gel foam to pack the canal? Like in this case, you will put some other material over this gel foam to pack the canal?
No, I'm using just the gel foam. And after I check the patient after 1 month. I give the patient the drops and antibiotics drops, and he put drops in the canal, and after 1 month we can check the adhesion of the graft.
Thank you.
What is the basically the preferable mode of the anesthesia? Should we go for the local anesthesia in these cases?
Honestly, I'm doing everything in general anesthesia because the patient is sleeping, the surgeon is in a comfortable way. You know, sometimes it's not easy, but you can do also in local. You can do also in local. It's more,
Yes.
it's more difficult because the patient, I don't know, in Italy, I don't know here, but in Italy, if the patient feels something in the ear, doctor, so please, I don't want. I want the patient sleeping, and I want to perform surgery in a quiet way.
Sir, basically we keep some 4% Jalocan in the canal for some time. Then after we'll start after the local infiltrations of the canal. Especially we are facing a problem with basically drill work. Whenever we are doing some drilling work, definitely the patient's having more problem. Otherwise, this type of surgeries we are performing with the local anesthesia also.
Yes.
Thank you.
It's possible, of course.
Professor Daniel, what is your preference of ear drops post-operatively, and how long you give it?
The drops, we ask the patient to put 3 drops a morning and evening for 15 days and stop.
Is it plain antibiotic or with hydrocortisone mixed?
Antibiotics, only antibiotics.
Okay.
You saw that the one hand technique is really dynamic. The difference between the 2 hand and 1 hand, that in 2 hand you put the holder, and of course you are working outside the tympanic cavity. So it's like a magnification of the microscope, but it's not so dynamic technique. In one hand you have to hold the endoscope, and you decide, you are the director of your movie, and you decide the angle of the scope. You have to decide to go closer or distant with respect to the ossicular chain, and with one hand you have to manage. It's more difficult. But of course this is probably, in my opinion, the best endoscopic technique. But you need a learning curve in order to manage the bleeding, in order to manage with one hand. And the secret is soft. Everything should be soft on the ossicular chain, on the tympanic cavity, on the incus, everything.
Hello. Yeah.
Hello.
Professor Daniel, those cases per-operative which you say that there is a glue also there, how your management differs in those cases?
The glue here, if there is the glue here, you saw that in this case was really not so. It depends, because if you have the glue here in the attic, it means that there is some fold closing the ventilation in order to create the glue here inside. So when you are doing the drainage, it's really important to remove also the folds collecting the glue here. If you have the glue here inside the tympanic cavity, it means that the Eustachian tube is blocked and the eardrum is integrum. So depends. In that cases, you have to put a tube, of course, and it's different because it means that you have a failure of the Eustachian tube. You can check with the probe inside the Eustachian tube in order to see if there is some fold closing. But anyway, the glue here, in the majority of the cases, is because there is a closing cavity.
Sir, if we are doing revision cases, same type of situations and the revision cases, anything extra precaution, or do you think that we should have a cortical mastectomy with this such type of cases in a revision cases or failed cases of tympanoplasty?
I don't perform nowadays mastoidectomy for simple tympanoplastic unless you have otorrhea infection after infection, and so in that cases you need the CT scan, and there is something wrong in the mastoid. Only in that cases, of course, you can do. but in the majority of the cases, you have to following the ventilation pathway. You have to check the isthmus, you have to open the isthmus. It's very important to preserve the mucosa of the tympanic cavity, because if you're scraping the mucosa, you can create an adhesion between the eardrum and the mucosa of the tympanic cavity, and you can have a reblock of the isthmus, and so sometimes you have this ventilation syndrome. So in the majority of the cases, if you are able to preserve the mucosa of the tympanic cavity and removing just the fold around the isthmus, is not necessary to do mastectomy. It's like, you know, a transnasal frontal approach. You have to try to preserve the mucosa and restoring the ventilation.
Thank you, Professor Daniel, for such a nice demonstration. Please give him a big round of applause.
Thank you very much. Thank you.
I must tell you, in India, most of the ENT surgeons are learning art and science of endoscopy ear surgeries by following your work. Thank you very much.
Thank you very much. Thank you. Thank you.
So I would now like to invite Dr. R.C. Kapoor sir to felicitate Dr. Joshi sir. I would like to invite Dr. R.C. Kapoor sir to felicitate Dr. Joshi sir.
Good morning, everyone. So we are starting with the next case, adenotonsillectomy. Adenoidectomy, sorry. And I welcome Vikas sir. And at present, is engaging the Boyle Davis mouth gag.
See, it should not go this side. Keep it. Let it go a little more. Correct. ठीक. Okay. Okay. मुझे बैठने के लिए ये पास में लगी नहीं तो can somebody fix this one? This is moving. इसको पास लाके फिक्स कर दीजिए ना. सिंपल स्टूल दे दीजिए, वो मूव नहीं करेगा एटलीस्ट. सी ट्यूब. ओके, कैन समबडी फिक्स द माइक्रोस्कोप? ये ऐसा मूव क्यों कर रहा है? थोड़ा फिक्स करो ना, थोड़ा. बस. ओके, आई एम गुड. एक टूथ फॉर्सेप.
हेलो.
हाँ, ये मूव करता है पीछे, पता नहीं क्यों. हाँ, ये हटा दीजिए, स्टूल दे दीजिए. वॉन्ड लगा दिया, रेडी. और ऊंचा. सक्शन चालू है इसका. थोड़ा और ऊंचा. बस. ठीक है. अभी क्या है ना, हेड ऐसे मुड़ा हुआ है पेशेंट का हेड तो सीधा होना चाहिए ना. यही तो प्रॉब्लम है. हेड शुड बी स्ट्रेट ना. करेक्ट. फिक्स इट ना समहाउ. अरे हेड हैंग कर रहा है पेशेंट. देखो आप लोग टॉन्सिल का ये स्टैंड लगा दो ना यार. अभी उसके लिए वही आई एम स्ट्रगलिंग. हाउ यू नॉर्मली फिक्स ए स्टैंड? तो देन डू वॉट एवर यू डू ना. सी, लेट मी नॉट स्ट्रगल ऑन दैट पार्ट. इसको लूज कहाँ से करते हैं? नहीं, हाँ बस थोड़ा सा लूज करो. ओके, थोड़ा लूज. बस. देखो हेड को सीधा रखो ब्रदर. हेड शुड बी स्ट्रेट. जो भी लगाना है करो, बट हाउ कैन यू स्ट्रगल इन पुटिंग. यहाँ लगाओ. चलो ठीक. इज इट? कांट कीप ऑन होल्डिंग ना. Okay. Scissor, please. Scissor. Okay, are we with the auditorium?
Yes, sir.
Am I with you? What
Yes,
image
sir.
are you getting?
Sir, only half of the tonsil is visible. Just.
Okay, so you're getting the microscopic image. Is the image quality okay?
Yes, sir. We are getting the microscopic image.
But how is the image quality?
And now this is good. Perfect, sir.
Okay. So see, first of all, at the outset, my sincere thanks to the whole department of ENT, Dr. Verma, Dr. Tripti, and all the colleagues to have me here. And I'm Dr. Vikas Agrawal from Mumbai. And the first case, can we have a complete silence in the theatre, please? Can we have a complete silence in the theatre? So there are some teething. Okay. So there are some technical snags, so which is normal. So we are waiting for the technical snags to get over. Let me give the history of this child. This is a 4-year-old child with history of chronic tonsillitis and mouth breathing.
Yes, sir.
So connector barabar lagao.
So it will be right to say that this is microscope-assisted coagulation adenotonsillectomy.
Yeah, microscope. I always use a microscope since 2009 that I started doing coagulation for tonsillectomy. I have always used. Yeah, change it, na.
So what made you to switch over to microscope?
Yeah, so there are 3 reasons for that. First of all, when you perform coagulation tonsillectomy, you want to do an exact work. Exact work means tonsil tissue consists of lymphoid tissue, and the muscles surrounding the tonsils are muscular tissue.
Yeah, exactly.
So if you want to perform a painless and bloodless tonsillectomy, then you have to be in the connective tissue which connects the fibrous, the lymphoid tissue of the tonsils with the muscular tissue of the fossa. So to get a correct definition of that, yeah, now this is better. Thank you, thank you, thank you. No, leave it, I'm doing it. Thank you. Perfect. Now you can connect the microscope. Okay, tell me if the microscope is focused for you. Can you make that picture a little better?
Yes, sir. Perfect.
Can you focus it? Fine
We can
focusing.
see, we can appreciate the pulsation, which are transmitted pulsation.
So see, now tonsil is in focus for me, but it's not in focus there. वो कैसे कर सकते हो? ये
Fine
भाई ये
focus,
तो
sir.
माइक्रोस्कोप का फाइन फोकस मेरे को तो चाहिए ना. This is in focus for me.
Yes, sir. No, it's okay, sir.
No, so see, right now the tonsil
So
is in
fine.
focus for me, but it's not in focus for you.
Yes, sir. That happens, sir.
Can somebody do with the camera setting? Because for me right now it is quite in focus.
So that's more important then.
Yeah, because see, if it is not in focus for me, then I'll not be able to do a complete proper work. Right now
That's
the
what-
tonsil is in complete focus for me. I believe it should be in focus for you, but it is not.
So we can manage, but sir, you can't.
Understand, but if somebody can the microscope... Sister, I know what is magnification. I'm talking of something else. Is there any camera adjustment apart from this? This is fine focus microscope. How is the camera? It's an inbuilt camera. Where is the camera inside?
So it must be inbuilt, sir, actually. So it's okay with us, sir. We are able to appreciate it,
Okay.
everything.
Anyway, I'm waiting for the coblation machine to work.
Okay. So, sir, we were on why you switch over to microscope, sir. You gave us the first reason,
I
sir.
will not listen to suddenly. Why a backup is not there? Yeah, get a backup. Okay. So, with the, I think there is some technical snag with the machine. So, I can take questions till that time. I think
Yes,
we'll
sir.
go for the external camera. Give us 5 minutes for taking care of this technical snag.
Yes, sir. No problem, sir.
External
So,
camera, please.
you-
Yeah. Sorry? Which is all right, normal, sir. So a question is that, is the pulsation of the tonsil which is seen, is that a concern? So I really don't think that is a concern, because this is the normal pulsation, because
Yes, sir.
obviously the left side, especially if Dr. Verma, if that's what you are saying, left side is pulsating more. So obviously this carotid artery, which is almost 1 centimeter away, so obviously we are not going to go outside the tonsil and outside the muscles. So there is absolutely no concern. Is the audiovisual giving the external camera live feed? Auditorium, are you getting the external camera?
Yes, sir.
Okay.
Yes, sir.
So since we are waiting for the coblation machine to get ready, so I was told that one of the concerns regarding coblation is bleeding. So if you do it under the microscope, one of the 3 reasons, you have lymphoid tissue of the tonsil, you have muscles of the tonsillar pillar, and then there is connective tissue which connects the lymphoid with the muscular. So your aim is not to remain in the lymphoid tissue, your aim is not to get into the muscles, your aim is to dissect the connective tissue which joins the lymphoid tissue with the muscle. That's a extracapsular tonsillectomy. You go outside
Exactly.
the capsule of the tonsil, remove the tonsil, but do not damage the muscles. If you do not damage the muscles, then the child will have a painless and bloodless tonsillectomy. And to do that, you have to identify where is the lymphoid tissue ending and where is the muscular tissue starting. Therefore, you require the microscope. Allow me to keep my mask down, because otherwise the sound will not be perfect. And this is a tonsil adenoid case, so obviously sterility is not that big a concern, so my mask is down. The second reason to do that is that you can put a camera system onto it and record it at the same time. So when you use
Yes.
a microscopic picture, you're not holding something with the endoscope, somebody is not showing it, so it's very stable. And you have a whole
Good teaching.
magnified
Yeah.
view. So with the camera, you identified the tissues better. You use it for recording. And the third reason is that with the magnification, you can actually see the blood vessels. You can see the paratonsillar vein. You can see the blood vessels. Everything you can see very, very clearly. So you can coagulate and you can adopt the right technique in right cases. So I'll be showing here 3 surgeries in one patient. One will be extracapsular tonsillectomy on the right side, where we remove the complete tonsil, not leaving anything behind, but still make sure that the child does not bleed in the post-operative period. So the typical bleeding time is when you are operating, that is on the table. Primary bleeding, which can happen within 24 hours. So that happens if you cut the, say, tonsillar artery, it goes into spasm and then later on it opens up. So how to prevent that? Can we have complete silence in the theater, please? Silence, please. And third thing is a secondary bleeding, which happens after 1 week or so, when there is an infection and there is a granulation tissue, which is removed by the force of the. Okay, so I think we have got the coblation ready. So let's start with the surgery on the right side, which is a extracapsular tonsillectomy. Now you can call it microscope assisted, coblation assisted extracapsular tonsillectomy. That will define it completely. Okay, so there was electrical fluctuation because of which the fuse had refused to work. And now that the fuse has agreed to work again, we are starting. Okay, are you getting the microscopic picture now?
Yes, sir. Clear, sir.
I understand that it's not very well focused for you, but
it's focused.
Okay, sound down.
Clear,
saline, please. Saline not coming. Okay. So, see, this is the uvula of the patient. This is the tonsil of the patient, right side and left side. This is the throat pack. Unfortunately, this is an uncuffed tube. We would prefer to have a cuffed tube, but this child had a very small larynx and the anesthetist was not comfortable pushing a cuffed tube. Can we have the yes, red rubber catheter, rubber catheter. So now what you can do is, can you have a thinner one? You can start off with a rubber catheter. Now this is even thick, thin one. This is very thick. This is very thick. Patla rubber catheter. Okay, so what you can do is, you can actually push a rubber catheter. Can you see that, sir? I have put a rubber catheter here and I am pulling the soft palate so that, but आप पतला मंगा करके रखिए, adenoid में लगेगा. We have to perform adenoidectomy also. So why I am putting this? Normally I do not put this, but here I am showing this because when you begin, what can happen? This, can you see this? Coblation wand has a suction. It can pull the uvula into your suction and then it can get damaged. And therefore what I am doing is, I have pulled this soft palate and the uvula. Now I'll start off with the right side tonsillectomy. So I'll pull the tonsil medially with a forceps. And can you increase the saline flow? Now I am taking the first incision.
Okay.
So my wand is getting directed towards the tonsil, and I'll try to get into the correct plane.
So the landmarks are same as the new conventional.
Yeah, but you have to pull it and see where the tonsil is ending. Suppose if the tonsil was ending here, I would have started here. Okay.
Yes, sir.
So see, the end of the tonsil is here. Therefore, I have not gone very laterally. Otherwise, I would not mind going a little more lateral. Okay, can you see these fibers? These are the fibers of the anterior pillar. So I am cutting through those fibers of the anterior pillar to get into the correct plane. Now, can you see this lymphoid tissue?
Yes.
I don't think the picture is very nice here.
So but here's a fine, so slight blurring is there, so we.
Yeah, I think it's not so well focused. But the picture is very nice here, but on the camera, Okay, can you see the paratonsillar vein here?
Yes, sir. Yes, sir.
That's the paratonsillar vein. If somebody can help, can have the lux forceps now. If somebody can help the focusing the camera, only focusing, nothing else. Because the picture quality is awesome for me inside the microscope. So I'm coagulating the paratonsillar vein. Can you see that?
Yes, sir. So for us, it's okay since we.
Oh, you can manage?
We have done all this, but for beginners, for PGs, I don't think they are able to appreciate it.
Sorry?
Sir, it needs fine focusing, sir.
Yeah, fine focus. No, when I fine focus, क्या हो रहा है? थोड़ा सा focus. Okay, I can work on a lesser magnification. Is this better? No.
No, sir. Earlier one was
See, when
better.
it is focused for me, it's not focused for you, unfortunately.
Yes,
Now it
sir.
is
The
absolutely
problem with integrated.
see. Yeah, it is in focus for me very, very nicely, sir. See, for me, it's
Sir,
completely
higher magnification was better than this, sir.
So I am on a high magnification of 1.
Yes, sir.
Is it
So
any
this is
better for you?
Yes.
So it's totally focused for me here, but for you, I understand that it's not well focused. ठीक है? I don't think I have a choice.
We can appreciate, sir, now.
Sorry?
This is better. Sir, this is perfect, sir.
I know it's not. You are being modest. So no problem. So I am now completing my incision and opening the tonsil like a book.
Okay.
Okay, can you see the planes opening up?
Yes, sir.
So I'll try to make it a little better focused for you so that I will compromise on little and you also compromise on little.
Sir, this,
No, I don't think I should be compromising more than this. I cannot.
yes, sir, you should not, sir. I think.
Yeah, because it's the child's.
Yeah, that's what,
Yeah.
sir. Patient
Okay,
safety
so
is
now,
first.
now see, this is the tonsil here. Can you see the upper pole? These are the
Yes,
connecting
sir.
fibers. I am dividing the connecting fibers.
Yes, sir.
Okay, and let me focus and show you that none of the muscle is exposed. Can you see that now?
Yes, sir. Very nice, sir.
There is no exposure of the muscle. Can you see the fascia or the muscles?
Yes, sir. Yes, sir.
Okay, so I'll again focus for myself and
Yes, sir.
continue the dissection. So this is what you need to perform in order to perform a painless and bloodless surgery.
Yes,
If you open up the fascia and expose the muscles, then it will be a painful surgery. And blood vessels also will be opened, so that will be a
Yes,
blood, a painful and surgery in which there can be bleeding. But if you are able to maintain the correct plane between the muscles and the lymphoid tissue, see, now let
Yes,
me
sir.
show you the upper pole which I have completely performed. Let me try to focus it for you. No problem. So can you see that? There is no muscle
Yes, sir.
exposure.
Wonderful. Yes, sir.
There is
Wonderful.
no
sir.
muscle exposure at all. Now I'm again focusing for myself and continuing with the surgery. Now you see, this is the lower pole. So
Yes,
upper
sir.
pole is taken care of. The middle part I am now dissecting,
Yes, sir.
and now I have reached the lower pole. So now tonsillar artery can come anywhere here. So what I'll do is I'll first coagulate along the whole length of the tonsillar artery. The tonsillar artery would travel somewhere like this. So
Yes,
I'm
sir.
coagulating along the length of the tonsillar artery. See, I'm not getting into the muscles. I'm only between
right.
the lymphoid tissue and the muscular tissue. So I know that the tonsillar artery would travel somewhere here. So I
Okay.
pulled the tonsil medially Okay,
sir.
I'm coagulating it and then dissecting on the medial aspect. Fine?
Okay.
See, the tonsillar artery is going to travel somewhere here. So we do
Yes,
not know
yes.
where. So I am assuming that it can come anywhere. So I am coagulating along the length of the tonsillar artery. Once you coagulate along the length, so I am not even coagulating the muscles, only the tissues between the lymphoid tissue. This is a little bit of lingual tonsils. Now the most medial part, this is the lymphoid tissue. So I'm just releasing the lymphoid tissue from the muscles by dissecting onto the lymphoid tissue, onto the connecting fibers between the lymphoid tissue and the muscles. So now, can you see that?
Yes, sir.
No part of the lymphoid tissue is left behind here.
Yes,
But
sir.
there is no bleeding, and it's highly unlikely that the child will have any bleeding from the
Yes.
tonsillar artery. So let me try to focus it for you again. Okay. Can I have the retractor, please? So I'll try to
That was-
focus on the fossa
Yes, sir.
and show you exactly what has been done. So is it focused
Perfect,
for
sir.
you now?
Yes, sir. Yes, sir. So perfect, sir.
है ना? So I have not
Yes,
exposed any muscle at
हाँ.
all. Right? There's
Totally
no.
bloodless.
No, forget about bloodless. Why it will be painless? Because the muscles are not damaged.
Muscles are not. Yes, sir.
So there is a covering on the muscle. This is a complete cover. Here it is an incomplete cover, but still there is no muscle fiber which is already exposed. So there will be no
Exposed,
myositis, and if there is no myositis, then there will be no pain. Now I'll have to shift to the other side.
Sir, please, sir, audience here would like to see the lower pole also, sir.
Lower, I just showed, na?
Okay.
So yeah, can we have the tube changed to the other side? Okay, I'll try to show the lower pole once more. Can we have the tube changed to the other side? So now I'll perform an intracapsular surgery on the other side. So this was extracapsular tonsillectomy. We are changing the tube to the other side. We hope that this child will not have pain and bleeding at all. But since this is extracapsular, he will have a little bit of, he'll require a mild paracetamol at least. But with the intracapsular surgery which will be done on the left hand side, even that will not be required. So this is a 4-year-old child. We understand that this child will not be able to do gargles and he will not tolerate if there is any bleeding. So you have to be really, really very careful. And it's just a matter of, see, everybody has a microscope in the operation theatre, right? So what is the harm in using it?
Sir,
You
you,
could-
told the 3 benefits of using microscope. One was stabilization, other was proper visualization, and third one, sir?
Recording. You could record it yourself.
Okay, thank
And
you.
you could see all those. I showed you the paratonsillar vein, if I remember correctly.
Yes, sir.
You could see all the muscle fibers very neatly.
Yes, sir. So there's a concern, some studies that long-term follow-up, there's chances of aneurysm of the adjoining vessels.
Come again.
What you say on that, sir?
Come again. Come again.
So there's a concern that on long-term study, that long duration follow-up, there's a concern that sometimes there's, because since we are using coagulation, it damages the vessels, adjoining vessels also.
Which vessel?
So
which vessels are we
like,
talking of?
Like the tonsillar artery is there. So there's a concern that long-term chances of aneurysm is there actually.
Aneurysm of which artery?
Like it's come from lingual artery.
Lingual
And,
artery. I
sir.
have not gone outside the tonsil. Where is the question of lingual artery? Lingual artery. Sorry, lingual artery. I mean, by that means he can also have aneurysm popliteal artery.
But some studies have shown that there is a concern of this, the branches, adjoining branches, there is a aneurysm is there, and it presents with bleeding.
No, I really don't think we are connecting properly. See, aneurysm of an artery will happen when you damage half the artery or the fibrous layer of the artery. Is that correct? If you damage the fiber, correct. So which artery have we touched? We have only touched the branches of tonsillar artery. We have not even gone into the tonsillar artery. That's what I'm saying. The tonsillar artery, when it enters the tonsils, it divides into 2 or 3 or 4 branches. We coagulated those branches. I have not even gone outside the tonsil. So where is the question? Even the tonsillar artery cannot form an aneurysm here. And the branches are so small that completely coagulated and, you know, merged with the local tissue. So absolutely not a concern at all. So I would like to see what study are we talking about.
Okay, sir.
Because honestly speaking, I am not a great, I do not read too much. I just apply common sense. Because there are so many people sitting in so many universities and they have to do some research. Because their promotion is dependent on some research. वो कुछ ना कुछ रिसर्च करते रहते हैं. तो अपन तो सिर्फ सर्च करते हैं, रिसर्च ज़्यादा करते ही नहीं. Common sense is the most uncommon available sense. So try to use your common sense and you will almost never fail. अच्छा, अभी क्या होगा कि मुझे इसको थ्रोट पैक को लगाइए ना. Apply the mouth guard. I'll have to put the throat guard. I am sorry, I'm taking a little time here because obviously it's a new setup for me. दीजिए ना, क्या दे रहे हैं? या नहीं, अभी तो ठीक है. आप मेरे को एक ये थ्रोट पैक निकालने के लिए कुछ दीजिए ना. So what I'm doing is, are you getting the microscopic picture? Just hold this, it should not come out. So I'm changing the throat pack from right to left because now I want the tube to remain on the right side because I'm going to operate on the left side. ठीक है? So I'm just changing the throat pack from right side to left side, and this is precisely what we do when we perform adult UPPP. Unfortunately, we do not have a case here. Coblation, please. Give me a pillar retractor. Are you getting the endoscopic, the microscopic picture?
Yes, sir. Yes, sir.
Okay. So now this side will perform an intracapsular tonsillectomy. Intracapsular tonsillectomy will consume little more time and little more wand. But here what you do is you go inside the tonsil and remove it. Are you able to, can illumination increase inside? For me it's very nice, but unfortunately what picture is going, I'm not very happy. So now we'll go to a setting of 9. Vikas, go to a setting of 9. So with a setting of 9, I'll be able to do intracapsular tonsillectomy fast.
Okay, sir.
Okay.
So what a clear
saline, please. Can you increase the saline? Saline, please. No, it's not coming. Increase the saline. Okay.
So what is the advantage of doing intracapsular tonsillectomy?
Correct. So here I will not even expose the muscle of the tonsillar pillars. So if I have a 2-year-old child, on the right side what I did, the chances of bleeding is almost negligible, but it's not, it's not almost impossible. Here we'll try to make it almost impossible. Almost.
Okay.
So here we will go from inside the lymphoid tissue and will reach the fascia, but will not even expose the fascia. So we'll leave a very, very small layer of the tonsil tissue behind. So this surgery is normally performed in 3 indications. One is a large tonsil in a small child, where the child is really very small, 1.5 years of age, 6 months of age, 9 months of age, 1 year of age, where you do not want to take any chance, and the indication is an enlarged tonsil. So the second indication is only an enlarged tonsil, which is not infected. So there, the obstructive sleep apnea to the adult or child which is being created because of the enlarged tonsil will be taken to that extent as you remove the lymphoid tissues. So if I am able to remove 90-95% of the lymphoid tissues, then obviously that much of obstructive sleep apnea will be taken care of. But this will consume more wand, more time. So you might have to use 2 wands. Once I perform and complete this, I might still have to use another wand for the adenoid, because the coblation wands have a working life of 14 to 16 minutes.
Yes, sir.
So if I ablate for 14 minutes or 16 minutes,
yes,
then the ablation power of the wand goes away.
Okay.
Okay. So the disadvantage is that you spend more wand, more time. Now I am pretty careful about this uvula. It should not come in my way. So can somebody just hold it? Yeah.
Uvula is the heart of surgeon.
Absolutely. So it should not damage the, my wand should not damage the uvula. So I am removing tissues layer by layer as we do adenoidectomy, and so far I am only preserving the uvula. Now the uvula is taken care of by my friend. What's her name? Lalit is actually taking care of the uvula. And the upper pole of the tonsil, you can see how deep is the upper pole. So unless you remove the whole upper pole, the sleep apnea in an adult or a child does not get taken care of. Are you able to see what I am doing?
Yes.
Is the image okay? Workable?
Yes. Yes, sir. Perfect, sir.
So see, I have not yet reached the
yes, sir.
muscles.
It's time.
I am still completely inside the tonsil only. So this is an incomplete tonsillectomy as of now.
Yes, sir.
So I'll perform a complete intracapsular tonsillectomy. I'll show you the fascia from inside, all around, but it's going to take a little time.
So, see, I think microscope plays a vital role in this.
Yeah, because you have to see the pathology very, very clearly. If it is an infected tonsil, I mean, you have to see the structures very clearly.
Exactly.
And if you are working with naked eye, obviously.
So there are chances of leaving a bit of lymphoid
Absolutely.
tissue there.
You will leave more tissue than you thought. With the microscope, you will not leave anything behind.
Exactly.
So even an intracapsular tonsillectomy would function like an extracapsular tonsillectomy.
Yes, sir.
So can you see that? That's the posterior pillar. There is little amount of tissue still there. So like a paintbrush, I am trying to remove all those tissues. But while doing this, I have to be careful that I do not damage the muscle fibers, because if I do that, then the whole purpose of doing this surgery is defeated.
Exactly, sir.
Okay, see
So,
how deep the superior pole is buried inside.
sir, as it seems, intracapsular is difficult than extracapsular.
I would say it both have their learning curves.
So, how much after doing extracapsular one should go for intracapsular?
There's no rule like that. Both are different jobs.
So there was a carry-home message for our young PGs, sir.
That technology is here to help you. You have to understand anatomy, physiology, pathology, pharmacology first, and then only you can jump onto prescribing medicines or performing surgery. There's no substitute for learning the basics.
Yes, sir.
Let me try to show you the fascia from inside in a moment. So I have, because it's not in focus for you, so I am not stopping now. Let me first finish the work from my side, and then I'll focus it for you and show you the fascia. And for the young PGs, by the time you will be out in private practice and or whatever you are doing, India would have prospered better than what it was in our times and what it is today.
Exactly.
Right? So India is a very fast growing nation, and the economy is also improving very fast. So maybe 5 to 10 years down the line, when you are deciding the fate of health of your patients, that time technology, you have to use technology. You can't say that I'll keep on doing the old way. Insurance would cover more and more things.
So
And
that's
I'm
what's like intracapsular. I think the wear and tear of band is more.
Is more, but
Yeah.
if the pain is less,
Huh. Yeah,
if the
exactly.
pain and the risk is less, then what is more, I would say, precious, wand or the patient?
Yes.
So certainly, see, in today's era, that's what I'm trying to say, that when I started in 2009, I had a lot of resistance. Everybody was saying, why you want to spend 9,000 rupees at that time for a wand extra? Why you want to spend some 7 lakhs into the machine?
Yes, sir.
But with tonsillectomy, we started on palate. With adenoidectomy, we went on base tongue. So obviously, the amount of money that we spend on these things was well spent for developing the whole field. Now, there are almost 1,000 installations into the country. So everybody is spending money, na? And the wand prices have
Yes,
also
sir.
gone up. So things always change with time.
Yes,
And
initially there's always a resistance to new.
yeah, you always, so when I did the robotic surgery, I was, everybody saying, what is the need for doing a robotic surgery? So obviously,
Yes,
when I learned coblation and started doing tongue-based coblation, my robotic surgery numbers went down, but first I learned the subject using the robot only.
Exactly.
So see how much depth you can still keep on going in. We are still in the tonsil. So one thing
Yes,
you can do extracapsular at the upper pole and intracapsular at the lower pole. That is also
Yes, sir.
possible, so that you can fast remove all the lymphoid tissue. See, I am going in still not, it's not ending still. This much of lymphoid tissue was there inside the tonsil fossa. So this is still complete, not yet 100% complete. So if you are doing intracapsular tonsillectomy, you have to go and do this much. You can't just remove 50% and say that your work is over.
Yes.
Hello.
Let me
Sir, good morning.
complete-
I'm Dr. Varsha. Hello.
Yes.
Sir, how will you identify that yes, all lymphoid tissue has been removed?
No, I'm
and we
seeing
have
it's
to
you are.
put the capsule?
Yeah. See, I'm just going layer by layer until I see the fascia. See, this is all lymphoid tissue. Therefore, you use the microscope.
Okay.
Therefore, you use the microscope.
That
If
seems very difficult to remove that upper pole.
Yeah.
Endoscopically, this endocapsular is very
Yes.
difficult to remove the upper pole since.
Yeah, that's what I said. You can do an extracapsular surgery at the upper pole and
Okay.
intracapsular surgery at the lower pole.
Right, sir.
Let me just show you the fascia by okay, let me just focus it for you. You will understand the difference in a moment. My surgery is not yet complete. Why? अभी दिख रहा है क्या? हाँ?
Help. Yes,
They're
sir.
getting it?
Yes, sir.
Okay. So I don't know if you are able to make out. See, this is the fascia from inside. Can you see this?
Yes, sir.
And
Yes,
this
sir.
is the lymphoid tissue still there.
Yes,
Are
sir.
you able to see the difference between the two?
Yes, sir.
So I will still remove.
So I
This
think upper
little
pole
bit
is
of
also left.
lymphoid tissue which was left. So if I go right till the, see now I am seeing fascia almost all around.
Yes, sir.
Can you see that? There is hardly any lymphoid
Yes.
tissue left anywhere.
Now, sir, upper pole, sir.
Okay. I'll show you the whole upper pole. Wait a minute. See that? There's nothing in the upper pole.
Yes, sir.
Okay. I will try to focus it better for you.
Yes, sir.
See, there's nothing in the upper pole. There's no lymphoid
Okay.
tissue. Now this child will have almost impossible to have a bleeding on the left hand side. Impossible. So this child can actually walk home by the evening. Now let's do the adenoid part. So we'll remove the microscope. We'll take some patties. This can come on this side. I'll stand on this side as we do for FES. Now any questions on tonsillectomy, both intra and extra?
There is a question from audience that is it the only bleeding part that that's why we are using coagulation?
Pain. Bleeding and pain both.
Yes.
What else is there in tonsillectomy? Apart from bleeding and pain, is there any other pain point? When you perform tonsillectomy, is there any other concern apart from bleeding and pain?
Hello, sir. This is Dr. Pooja.
Yes.
Sir, intracapsular tonsillectomy is being done just to lower the risk of bleeding and to lower the amount of pain.
Correct.
Has it got some other advantages too?
Yeah, so if you are operating on a voice professional, so I do a lot of surgeries on, I am in, Bombay, na? So Bollywood is there and there are a lot of actors and singers. So if I have to perform tonsillectomy on a singer, he would not even, can I have this here? A little chance, well, that is fine. He would not even want a little chance of voice change, right?
Okay.
So you do not even want to expose the muscles of the tonsillar pillars or the fossa for any fibrotic change to happen. Can I have some patties, please?
But sir, in case we leave the tonsillar tissue, how fast does it grow back?
Yeah, so when I started doing the surgery in 2009, I learned it.
Right.
I did some workshops. I learned from some workshops. And I was obviously not that thorough. So I used to leave some tissue behind. Can we remove this? No. Okay, so, okay, white balance. Okay, thank you. Can this trolley come here? Can I have one more patty? So I am packing the nose of the child. The child also has got grade 4 adenoids. I am packing the nose with adrenaline and whatever saline adrenaline patties. Yeah, so then I used to leave some tissues behind And I distinctly remember one child coming with an episode of tonsillitis after a year of the surgery.
Okay.
He got 2 episodes of tonsillitis because I had left a lot of tissues behind and I had disturbed the natural mechanism of the tonsil. The tonsil has crypts, right?
Right.
I had removed the crypt, so that surgery is also called cryptectomy, which is absolutely not recommended. So if you only remove half the tonsil, you have removed the crypts, the cleaning mechanism of the tonsil is disturbed, and now you have not removed the tissues which are prone to infection. They'll keep on getting infected, and another child actually got a peritonsillar abscess.
Okay.
So those 2 I distinctly remember. Apart from that, there are a few incidences. I did surgery in a doctor and left a lot of tissue behind at the lower pole.
Okay.
So the doctor had a foreign body sensation. Okay, but
Right.
this is the what? Which camera is this? Okay, give me a. Are you getting endoscopic picture? No, no. Mouth gag. Are you getting endoscopic picture?
Yes,
No?
sir.
Okay. So I have decongested the nose a little bit, as much as possible.
Yes, sir.
Do you have a suction or something? And I'll, yes. No, no. Yes, 100%. So see, I am, give me something to hold, forceps. Tight, please. Tight kar do, tight kar do. So now we'll bend the wand. Can the external camera, please? Audio visual, the external camera, please. Auditorium, are you getting the external picture?
Yes, sir. Yes, sir.
Okay, so this is the wand. Now this is upper 3/4 and lower 1/4. This is the angle on which the wand has to be bent for doing an adenoidectomy.
Okay.
Now, if you bend it acutely like this, then the suction channel of the wand will not work. So you have to gently bend it at this point. See. Okay? And in the lower part. Now this wand is bent by almost 40 degrees, 35-40 degrees, correct?
Yes,
so now
sir.
it can reach the upper part of the adenoids easily. Let's check. Can you turn it towards me? And ये क्या किया है भाई? ये क्या किया है ब्रदर? एक कम टाइट करो ना थोड़ा सा. बस 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 बस. 9-3. So now can you pour some saline? So I am asking for some saline to be poured. नाक में saline pour करो ना. डालो. अरे एक अच्छा ना नीडल की जगह एक ये ले लो. ऐसे हाँ अच्छे से pour करो. So I am asking for some saline to be poured into the nose. I do not want to introduce the suction.
Okay, sir.
How is the image quality?
Yes, yes, sir. Now
Workable, na?
clear. Okay, sir.
Workable. Okay.
Clear, sir.
डालो लेफ्ट साइड में. हाँ अच्छे से.
Yes.
डालो अच्छे से. Okay, so if there is any mucus, you pour saline into the nose. Okay.
Sir,
so
what
now,
are the grade of adenoid in this patient?
What are the?
Grade, it seems to be grade 1 only.
So the can the external camera show the external camera? Can you show the X-ray there? वो X-ray दिखाओ.
Well, is it required now to do this in this patient, adenoidectomy?
Why not? Can you see the X-ray there?
Sorry.
X-ray external camera, please. X-ray दिख रहा है क्या? हाँ
Yes,
तो
sir, yes, sir.
X-ray में कौन सा ग्रेड है?
Seem to grade 2 or 3, sir.
करेक्ट. तो X-ray में ग्रेड 3 है ना. अभी क्या हुआ, मैंने इसको पूरा नीचे खींच लिया है, प्लस इसको थोड़ा स्टेरॉइड ट्रीटमेंट दिया है. दिस इज ओनली shrunk right now. This will again increase in size. So when you see adenoids, remove them completely, na, because what is the point of not doing it? Is there any
Sir,
risk
do
in
we
doing it?
on the basis of X-ray finding or endoscopic finding, or both?
No, so this is a question. See, X-ray is obviously not that accurate because X-ray depends on the angle. Endoscopy is more important. But even if I see a grade 2 adenoid and I'm anyway going to remove the tonsil, I will not leave it behind because this can increase any time. The child is only 4-year-old, right?
Okay, sir.
Okay.
So
now,
if there is both tonsillectomy and adenoidectomy, then you will operate
correct.
grade
So
2
grade
or-
1, grade 2 adenoid, if there is no tonsil, I would put on nasal spray. I will not operate. Okay. Now this is the eustachian tube. This is the torus tuberous.
Can say, sir, we are not seeing your endoscopic pictures now.
Okay. Endoscopic picture, please. Audio visual endoscopic. Audio visual. Ready? Let me know. Endoscopic picture मिल रही है क्या? Auditorium.
Yes, sir. Yes.
Endoscopic picture आ रही है?
Yes, sir. Clear, sir. Clear,
Okay.
sir.
So now this is the torus tuberous. This is the torus tuberous. This is the eustachian tube here.
Yes, sir.
This is the upper boundary of the adenoids which we described in 2016, first time on the planet. And that will be the superior boundary, which will be the periosteum below the sphenoid bone. So we'll start with the, no, not needed. We'll start with the superior boundary. Can you see those small vessels being coagulated?
Yes, sir. Very.
And can you see the periosteum below the sphenoid bone very, very clearly?
Yes, sir.
So this is our superior boundary. See, this is bone. So you don't remove the periosteum, you only remove the adenoid tissue and go till the periosteum. Can you see the periosteum very clearly?
Yes, sir. Clear, sir.
So don't remove the periosteum, that is your protection to the bone, but do not leave any adenoid tissue behind. That is your superior boundary. Can you see that small vessel?
Yes, sir.
So coagulate it if you get a vessel. That is our superior boundary.
Okay, sir.
So in 2016 in Indian Journal we have a paper which defines the boundaries of the adenoid surgery first time on this planet. Okay?
Yes, sir. That's great, sir.
So go through that paper if you want to. Actually anyone doing adenoid surgery should go through that paper.
Okay.
Because that is the boundary of a surgery. It was never defined before. So that's, I feel very happy to have contributed to medicine, medical science, by defining boundary of a surgery. Why not?
Yes,
so if
sir.
you are anyway doing surgery, why not do it completely? So this is the periosteum below the sphenoid bone, completely removed. Now we'll debulk the adenoid and go towards the posterior boundary.
Yes, sir.
Which will be the buccopharyngeal fascia.
Right, sir.
Okay, so this is the superior boundary completely defined and cleared. So if you do,
Yes, sir.
now all this you can coagulate and leave. Now
Right,
this is we'll go towards the posterior boundary here. This is the lateral boundary. Lateral boundary, anterior is the torus tuberous, and there is a little amount of tissue on the torus tuberous, which is called tubal tonsil. Somebody wants
Yes.
to talk a lot in the theater. Can you take the microphone and talk? Don't talk behind my back now, please. So see, I am not going inside the muscular tissue. I am only submucosal. So this lymphoid tissue, and this is 5 to 6 millimeter away from the eustachian tube orifice.
Yes.
So this will never cause a eustachian tube dysfunction because I am pretty away from the eustachian tube orifice. But since the lymphoid tissue on the torus tuberous is already removed, you will not get a recurrence on this. Otherwise, this part hypertrophies. I have many
Right,
patients
sir.
with that. And then the lateral boundary posteriorly is the fossa of Rosenmuller. And very
Right.
near to the fossa of Rosenmuller is your carotid artery in this part. So this is
Right.
the
Yes,
fossa of
sir.
Rosenmuller. But here the skull base is very thin.
Okay.
So I am only remaining submucosal. So I can never damage any structure. Unfortunately, the camera image is not that great. Can we do anything more to the camera? Okay, is it a little better for you now?
Yes, sir. Yes, sir.
So now, see, this is the torus tuberous. This is all fossa of Rosenmuller.
Okay, sir.
So while operating in this part, it's better to direct your wand medially and see what you are doing.
Okay.
Now this is the fossa of Rosenmuller completely cleared. See how deep is the fossa of Rosenmuller. There is a little bit of tissue here which I am still removing. It's fine if you do not want to remove it and you can just coagulate. See what I am doing now is only coagulation. That
The concept is to be under vision.
Do it under vision, absolutely correct. So nothing blindly. Can you see that? Very deep
Yes,
fossa
sir.
of Rosenmuller. And I am coagulating those tissues. Okay?
Good amount of tissue is there.
Good amount of tissue was there. Now we'll remove. Now can you see those vessels? If you see those
Yes,
vessels,
sir.
coagulate them.
Yes, sir.
Now I am going for the posterior boundary, which is the buccopharyngeal fascia. So lateral boundary was taken care of, layer by layer, layer by layer, layer by layer, always. Okay, can you see the buccopharyngeal fascia?
Yes, sir.
It's
Yes, sir.
absolutely white, pearl. And see, this is the adenoid, which is pinkish. Okay. So
Yes,
now
sir.
that I have got a hang of the fascia, I will define the fascia all around.
Yes, sir.
Okay, can you see the fascia over here also?
Yes, sir.
So I am not going very deep inside the buccopharyngeal fascia, but can you see the, right? That's the fascia. Now,
Yes, sir.
I am not happy leaving even this much of tissue behind, so I will try to remove this tissue as well. And I'll remove each and every bit of the lymphoid tissue so that never in this life this child gets an adenoid enlargement again.
Yes, sir.
And at the same time, I'll not open up the fascia, because if I open up the fascia, then the child will have pain. Why? Because the muscles will be exposed.
Exposed.
Okay, now see how much of third dimension depth we have removed. Can you see that?
Yes, sir.
So we started from here and we went right till the posterior boundary, which is there. Whatever little is pending here, I'll still remove. Now we'll just debulk and remove this tissue. See what is happening right now. This was my coblation wand is getting blocked. It's getting blocked because of two reasons. One is that it's now losing its power, right? And second, can you see all those deposits?
Yes, sir.
But deposits of carbon onto the wand, so you can keep a toothbrush ready to remove those carbon. Do you have a toothbrush? No. A sterile toothbrush if you have. Okay, now inferior boundary. Can you see this inferior boundary?
Yes.
That's the passavant ridge. Can you see the movement of the muscles?
Yes, sir.
When you are near the passavant ridge, the transverse muscles, constrictors of the pharynx, they start dancing, right?
Yes, sir.
So be careful. Do not damage those muscles. But I am removing every bit of lymphoid tissue which can create obstruction later on. Now if your scope is fogged, you can simply clean it on the tissues like I just did.
Yes, sir.
You don't need to come in and out. How many times I have come out so far?
Not even once.
So people say that your wand gets blocked and you have to come out. It's all a matter of practice. Now, this wand is losing its power. I told you, na? So let me see if I can finish the surgery. Well and good. Otherwise, I'll ask, since today is a sponsored thing and the company can sponsor another wand. No, don't open it right now. Don't open it right now. If I am unable to finish this surgery, I'll ask you to open. Now see, this wand is now losing its power because I have already used it for more than 14-15 minutes. Now this is a bonus. However, if you have a toothbrush, now right side work is complete. Now I'll go on to the left side. Okay? Yeah. Do you have a toothbrush by any chance? हाँ तो चलिए करिए ना पूरा चारों तरफ से. So we are cleaning it with the scrubber.
Okay.
Which is even a better thing to have. So I have just cleaned the tip with a scrubber. हाँ करवा ठीक. Okay. So let's see if we have a better. Now see. डालो ना पानी डालो ना अच्छे से डालो जोर से और जोर से. Yes, thank you. So let all this mucus get sucked. Give me a moment.
Yes, sir.
I know I'm taking much more time, but see, as I said, na, it's a new setup for me also, and it's demo, na. So see, this wand still has not completely exhausted because all the three wires are intact. So this is the eustachian tube, this is the torus tuberous, and this is the adenoid. So the power of the wand definitely has gone down as from before, but still workable. So I will not open another wand at this point of time. I will try to do as much as possible with this wand.
Okay.
Now see, so once the power is going down, it's not melting the tissues, and therefore, and the suction channel is getting blocked. See, this is the sign of suction channel getting blocked. Now the suction is open, it will start working. Got it?
Okay,
so
yes,
when you are getting bubbles, that means your suction is not working. So
okay.
you don't need to take it out. You keep on pressing on the paddle. Whatever tissue is stuck in the at the tip.
Okay.
Because this wand is now not as powerful as before. See this. And then people say that no, technology is not good. Technology is good because we are now overusing the wand. You can say that why the wand should not even last for one case. So if you had have done a complete tonsillectomy on both sides, then the wand power would not have got reduced, and one wand would have been completely enough for one case. But since I did an intracapsular surgery,
yes, sir. That's why
I consumed the wand.
Yes.
So you see how impressive it was on the other side, and this side it's not so impressive, but still workable.
Yes, sir.
So now same thing I am doing on this side, but a little faster than the other side, because I have already explained and I should not waste time. Dr. Daniel would be ready with another case. Has his case already been induced? Yes. Yeah, so I'll finish off in the next 5 to 7 minutes at the most. Sorry? Honey. Okay, so see, the wand is still working, right? Yes. And I'll be able to complete the surgery hopefully with the same wand. Now can you see the fascia here? That's the fascia. Auditorium, please.
Hi, sir.
Yeah,
Dr. Vikas, Dr. Akhil Kukreja this side.
Hi, Akhil. How are you? Very nice to see you.
How are you, sir? Sir, do you find any difference, this is a younger child, and if you have to do adenoids in a 11-year or 12-year-old child,
Yeah.
so any difference in the tissue of adenoids?
Yeah. So
Any
the
other-
older the child, generally the tissues are that more tough, fibrous.
Yes, sir.
And your consumption of bond is that much more higher.
All right.
Your question is very, very relevant.
And usually reaching the
Can
posterior
you be a little
boundary
loud? I
in-
cannot hear you though.
Reaching the posterior boundary in an adult child.
Yeah.
So, what is your experience in that?
Always you must. See, because if you leave little tissues behind, they will keep on secreting. And the
And,
postnasal drip problem will always remain.
And
even
what
as
is
an
your
adult.
experience with recurrence of adenoids after copulation adenoidectomy, even after?
See, the younger you operate, the more the chances, na? So people say that in younger children operate less. I say operate more. Because he has those many years for the adenoid growth. But even when you are doing a 35-year-old, why to leave tissues behind? Why not do a complete work? Spend more time. Do a complete work. See, it is your brand. Once you operate on somebody, if there is any problem later on, now this is the torus tuberis. Okay.
Yeah.
See, this side we have lot more tissues on the torus than the right side.
Right.
So I am removing all the tubal tonsils here. Akhil, can you see this?
Yeah, sure.
So we do not know how much this will hypertrophy later on if we leave. So why to leave? But at the same time, don't give a complication.
Secondly, sir, what's your exposure through the oral cavity with a 70-degree endoscope for adenoids?
Yeah, can we have a 70-degree endoscope, please? So I'll just show you how it looks with a 70.
Just,
Try to
if
do
you can
everything
show
with
boundaries
a...
through the 70-degree approach.
Yeah. I'll just show that approach as well. So now see, this is the fossa of Rosenmuller, almost cleared. Superior boundary almost cleared. So for adenoidectomy, I believe there is no better tool on this planet as of now than a coblation device. So my surgery is over. I will just take 2 minutes to show the approach from the oral side using a 70-degree or a 45-degree, whatever you have. So there's a little amount of lymphoid tissue here. Can you see this?
Yes, sir.
So turn your wand medially. Don't turn it laterally and operate because you will not see what you are doing. Okay.
Sir, when you consider to remove
Now,
the lingual
still a little bit of tissue behind the tubal tonsils,
Yes,
behind the torus tuberis. I will show it from the oral side. Okay. So another 2 minutes, Dr. Daniel can actually start his case. I'll just finish in another 2 minutes. And I'll take questions on the adenoid while he's preparing. Oh, hold on. Okay, are you able to see? See, this scope is much cleaner actually, much clearer. Wand, please.
Excuse me, Dr. Vikas.
Yes.
Dr. Alok here. I want to ask you one thing. Why do we want to remove this tubal part of adenoids?
Yeah, because if you do, see, these all are part of the lymphoid tissues of the Waldear's ring. Once you remove one part of it, the other tries to compensate. And
Right.
I have many patients who came back after 4 or 5 years with gross hypertrophy of the. Okay, so this is the view from the 70-degree. So you see better view of the tissues behind the torus tuberis with a 70-degree from down. Rest everything is better with a nasal endoscope. Are we good?
Yeah.
Have I answered your question why we want to take off the torus tuberis? So that it does not hypertrophy in the later part of life.
Okay.
Sir,
Are
when
we
you
expecting
consider
any nasopharyngeal
lingual
complications
tonsils,
here? No, because this is the bone. I have gone very close to the bone here. Bone cannot cicatrize. But in this part, you have to respect the mucosa. I have preserved the mucosa here because this is the part which is going to come closer. Anything else?
Sir, do you think to remove the lingual tonsils in adult patients when you are doing the tonsillectomy, sir? Because the same thing can happen.
You are absolutely correct. So if we are doing tonsillectomy, adenoidectomy in a small child, we always look at lingual tonsils. If they are already large, we definitely perform a lingual tonsillectomy. If they are not, then we do not do lingual tonsillectomy, but we inform external camera. But we inform the parent that there is a possibility that lingual tonsils can enlarge later on. Why we do not do lingual tonsillectomy? Because lingual tonsillectomy is a totally different ball game altogether. When you swallow, there is going to be pain. The lingual tonsils have a little chance of bleeding. The giving anesthesia is more difficult. Adenoids bleeding is almost impossible. Tongue is a very fast mobile structure. Bleeding from lingual tonsils is little more probable than the adenoids.
Yes, sir.
In adults, we never do because the adults have already passed their age of enlargement, the spurt, right? So adult tonsillectomy, why you perform? Either because of sleep apnea or because of infection. Infection, obviously, you do a tonsillectomy, matter is over. If it is sleep apnea, then most of it is not only because of tonsils, it's also because of the palatal muscle. So we do a UPPP. Now, this answer to this question is, day before yesterday, I have performed a drug-induced sleep endoscopy for a patient, 35-year-old, who came from Hyderabad, nicely operated for zeta and nose, but now he has got a very large lingual tonsil, which was present before also. So it was there before, and his surgery was incomplete because tonsillectomy was not done. So he is now posted for a lingual tonsillectomy.
Sir, do you prefer to do the tonsillectomy in like 35 years old age? Because after the tonsillectomy, most of the patient having that problem, that sore throat, recurrent sore throat, pain. And we are getting a good result in less than 10, around 12, 13 years old child. Very good result. But in later age, the patient is not so much satisfied with the tonsillectomy.
So the procedure follows your diagnosis. What is your diagnosis? Why the patient has the problem? Is it documented tonsillitis and nothing in the sinuses? Then definitely he'll get result. But if the problem is the crooked septum, turbinate hypertrophy, or some sinusitis or allergy issue, then doing a tonsillectomy is not going to give you
When we see that tonsillitis, it is also having the allergic component also. So tonsillitis is not always effective.
Correct. So obviously you have to make a diagnosis. Now if your tonsil is enlarged because of allergy, how removing the tonsil is going to give you the answer? No. You have to treat allergy, na?
What about the mechanical blockage like grade 4 tonsils?
100% you'll get your results. It's impossible that you'll not get it.
With a guarded prognosis, I can say.
See, guarded prognosis.
Patient may have a problem after that.
See, guarded prognosis you can give everywhere.
Yes, sir. Yes, of course.
Let me tell you, what will you do on your own brother if he has the problem? You do the same for every patient.
Yes. Yes, sir. Yes.
See, you give guarded prognosis for court cases and all that. Nah. In your mind, what is the problem? We are not black coat, we are white coat people, right? So what you do, what you want to do for your own brother and your own mother and your own father. I do the same. And there's no problem.
The result with the tonsillectomy in 10, 12 years is very good. Very good, sir. The post-operative patients, even after the 6 months, the patient is very satisfied. But the same surgery we are doing in a 20, 25, 30 years, the result is not as much good as we are getting in the lower age group.
We are repeating the same question. If the diagnosis is the same, result will be the same. If the diagnosis is in question, if the patient has got a deviated septum, turbinate hypertrophy, his mouth breathing, or he has got allergy, or he has got ethmoiditis, you do a CT scan on every patient before touching the tonsils. You'll get your answer. You do a CT PNS. I do it in every single patient of ENT. I do a CT PNS before touching either ear or throat, anywhere. You'll get your answer. So there will be some amount of ethmoiditis, there will be some amount of deviated septum which is responsible.
Yes, suppose there is a DNS and there is a sinusitis.
So you have to tackle that also, na, how you only do tonsillectomy.
The both things that should be, the tonsillectomy should be performed and then simultaneously the medical treatment.
And allergy also has to be treated.
Thank you, sir. Thank you.
Thank you, Dr. Vikas.
Thank you. I think Dr. Daniel would be ready with the case.
Wonderful presentation, sir.
Doing tonsillectomy or lessening the chances of lymphoma also.
So I thank all the moderators for a very interesting
okay.
session. Now I request Dr. R.C. Kapoor sir to felicitate Dr. Varsha ma'am. Go to 5 years. On examination, as we can see, in past, there is a grade 4 retraction with outer aortic wall erosion and cholestoma. In past tensor, we have a grade 3 retraction. We can see a bit of discharge also. Left ear has a retraction of grade 2 in past tensor. So coming to tuning fork test, it was negative in both the ears by 512 hertz. Weber's was lateralized towards left and ABC was equal in both ears. And this is the pure tone audiogram, which shows patient has bilateral moderate conductive hearing loss.
Ora faccio, prendo la fascia subito o aspetto?
Entire CT of temporal bone.
Non è la blade?
It shows, yeah, this is better. It shows a soft tissue attenuation in the mastoid cavity, which extends to epitympanium also. There is thinning of the dural plate, and rest we'll hand over to the OT.
Do you have dissector?
Autologic, yes.
And in the scientific program, the case had been written as endoscopic tympanomastoidectomy.
We have a smaller one.
However, this case has been changed and it is now tympanomastoidectomy by microscope. The chairperson of this session, I would request Dr. S.P. Singh and Dr. Anupam Kala to chair this session. Dr. Manu Malhotra, Dr. Achin Pant, and Dr. Nitin Sharma, I would request to please moderate this session.
Go. 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 Goes. Goes. Goes.
Goes. Right goes.
Go with the bipolar. Okay. Beh, tieni qua così di varicata.
Non vedo. Così,
Ok. Forceps? Sorry.
Scissor.
Go. Dovrebbe essere sufficiente.
Loro poi lo sanno cercare bene.
Okay, can you
Can you
make
dry it?
dry?
Yes.
I know that you are so clever.
Okay.
Can I wash the surgical?
Saline.
Good morning, Dr. Marchioni.
Good morning. Good morning. Can you hear me? Can you hear me?
Yes, we can hear you.
Okay.
I'm Dr. Manu speaking from the auditorium.
Okay. So we started the incision, but now we can try to put the microscope in order to show the line of incision. This patient has a posterior erosion of the external auditory canal, so no sense to do transcanal endoscopic approach. In this case, a canal wall down procedure was planned because you have no possibility to restoring ventilation or something like this. In this case, you have to try to remove all the cholesteatoma, and you can do also obliteration cavity. We will see at the end. And after we have to reconstruct, but in a canal wall down fashion. So now we can try to put the.
You don't want to show them.
Sir, we'll request you that the camera be projected in such a way that we can see how you inside. And before that, sir, I'll also request you to show us the instrument trolley. What instruments and what drill you will be using for the surgery?
The instruments.
Drill
Yes.
and the drill, sir. What drill you will be using for the surgery?
Drilling.
Drill is binaire.
Okay, binaire. Okay, okay.
And instruments are routine.
Yes.
All are storage instruments.
Okay. So
You using
we have the
isolate-
binaire as drill. Let me see. Okay.
Qua facciamo
Ma adesso, are you able to see the microscopic view? No.
Microscopic view दिख जाएगा राजू?
Perché?
allora?
Sì, mettiamo i retrattori.
Non facciamo per niente.
Ma che cazzo vuoi far vedere? Che non vedi che sono si casino. Cioè.
Sister, can I have the retractor?
Do you want to see the endoscopic view of this case, the eardrum, etc.? Hello? Do you want to see the
Yes,
the
yes, we
endoscopic?
can see the
Is it possible
incision
to-
that
to
has been
show
given.
them the endoscopic
Yeah, we
view?
can see the
I
microscopic
don't know
view.
if because it's la colonna è là si incasina.
Yeah, of course, like endoscopic picture will help understand
Yeah,
the
but
disease.
we have just a problem because the tower is outside, so it's possible to show them. Okay, so now we can check just the endoscopic view, just in order to show you. So now we can see, this is the external, what is this? Star. Che cazzo è sto bagaglio? Okay, so this is the line of incision, you can see this one, okay, and the situation.
We don't see, we are not able to see that. I think these audiovisual people should project the endoscopic view on the auditorium screen.
So?
Yeah, now we can see that.
Now you can see,
yes.
Okay, so
Yes.
you can see this is the eardrum, and look, the cholestatoma is here. This is the old posterior wall erosion, and the cholestatoma is here, you can see.
Yeah, we can see that the posterior superior wall is eroded and the
So-
colostoma is down into the antrum.
So the posterior canal is already eroded. So you have to do an open approach and canal wall down. Because
Yes.
it's not here the problem, but it's here. So the value of the endoscope, of course, is here. But here there is no cholestatoma. The problem is the erosion of the posterior canal. So we started with the incision. You can see this is the post retroauricular incision, and we collected the fascia. This is the fascia. And now we can go microscopically and performing the canal wall down. We have electric. So now we can have the picture of the. Are you able to see the microscopic view?
Okay.
Yes,
Okay, so this
currently not.
This is the external auditory canal. Can you see?
No, we still can't see the microscopic view. We can see the external view.
Okay.
Yeah, now we get it.
Now, do you see?
Yes.
Non è fuoco. I don't know why it's not so. The focus is not so good. Not mine, because I'm able to see good, but for you. Where is the focus of the camera here?
The focus.
My focus is this one.
This one. No, but it's not. For example, now this is my focus, but you are not in the. Oh, you see? No. Ma io vedo sfocato così,
Within the microscope.
Okay.
You can change the height.
Because he's seeing, he's watching on focus,
For me now I can see in a good way, but not in the camera. So I don't know how to manage the camera in order to show them in a good way. There is a focus on the camera, not on the microscope, on the camera.
On the camera.
Where is the camera? You know where is the camera here? The camera system. No, in centro casa.
No camera.
No, yeah, but probably is inside, because in order to have the signal, probably you need to have something to focus the camera, because certo che cambia. So now, if you want, I can try to do like in exoscopic view. I can try to see the monitor. Mi date gli occhiali, ragazzi? Because the problem is that there is no good connection between the focus of the microscope and the focus of the camera. So anyway, we are doing the incision.
Professor Marconi,
yes.
We want to know that do you plan your incisions, your periosteal incisions, in such a way that in the peroperative period you have to reconstruct or obliterate the cavity created after canal wall down procedure?
No, I don't want to. I'm doing a canal wall down. I'm sorry, but I'm not able to manage this microscope. No, this is good. It's just because it's too far, the focus is too far from the patients. I don't know why. Let me check.
It seems that Professor Daniel has taken an anteriorly based flap.
Yes. I'm doing anteriorly based flap, and I'm too distant from the patients. I don't know why.
We call it a Palwal's flap or modified Palwal's flap. It's based anteriorly.
No, yes, but here I can't do the focus because I have to work in this way. Allora sei stato tu che sì, infatti sei stato tu. Okay, now it's okay. Okay. So this is the anterior based flap, and at the end I have to cut this flap, and I have to suture this flap in order to do a meatoplastic. This is the tip of the mastoid. And go to the bone. Of course, you can do in a different way, it's not a problem. I'm doing like this, usually. Do you have a forceps? I'm sorry regarding the view of the microscope, because I can see in a good way in a focus, but you are not able to see in a good way.
We'll request the audiovisual people to, for the sake of the audience, we can't, a little bit of fine focusing is required.
Yes. Now, the only way is to use...
I think microscopic view of the surgeon may be okay, but here what the picture we are getting on the screen is not very
I can
clear.
do like this.
Yeah, now it looks perfect.
Yes, but
yeah,
in this
it
way,
looks good now.
in this way, I can work to see the monitor, not to see the microscope, because if I see the microscope, I'm not in a good focus. So it's like to use the exoscope. I don't know.
Cambia anche a te qua?
Senti, non mi incasinare però, perché...
Sir, how do you determine the posterior extent of the periosteal incision?
This is we should be do larger, because in this case you have to use all the landmark. The landmark are the lateral sinus, and the dura of the posterior fossa, the middle fossa, so it's really important to do large vertical. So now we can cut here the muscle. No ragazzi, c'è questo. Togli.
Sir, many surgeons, they prefer to use a knife instead for periosteal incisions. With the view that this cautery causes some amount of loss of shrinkage of the periosteal tissue that causes some trouble while we are stitching it back.
Go please, go. Go. No. It's you have to clean. Yeah, but regarding the flap, you can use superior based flap, posterior based flap. Right. So it's just a question of behavior of the surgeon. I'm using at the end. You go. Okay. I'm using at the end this flap, right? Go. Okay. To perform the hematoplastic. Sometimes it's because if it's possible, I want to do. Do you have a dissector? Obliterative technique. So this is the external auditory canal. It's not good, the focus. It's not good. In this way I'm working but without the focus. So for me...
Sei senza fuoco?
Io sono senza fuoco. I'm trying to working in not with a good focus just for you.
Yes, we can see the spine of Henle, the cribriform area behind it, and the root of zygoma. So we can see the posterior canal wall and the flap is being lifted above it.
Retractor, please.
Yes, very meticulously, and the pulvulus flap, anteriorly based, is being pushed with the help of retractor.
Ferma. This is to, do you have a bigger retractor? Because this is too small. Okay, I'm working just to see the monitor. So it's not so easy, honestly. Just because of you. You can see this is the posterior wall of the canal, and now the incision is really important to go there. Bipolar. Right. Go. Or do you have the, come si dice, gli incini? Vai. Hook. Just because this is not, vai, go.
Go, sister.
Go. Because this retractor is too small.
Possiamo provare però con questo?
Prova. Intanto con quello è uguale, se che cazzo vuoi provare, dai. It's too small. No, it's not the right retraction. We need a bigger one or something like a hook. Tieni. Tira sul padiglioncino. Ecco, guarda. Ferma lì. Give me to wash the surgical field, please. To do this, you need a large retractor, honestly. Bipolar, please. Go. 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 Go.
Sir, since you have planned canal wall down procedure, it seems, would you not like to do a myectomy at this stage? Would you wait for the cortical mastectomy to be done first?
Now, the first step is to cut the skin of the external auditory canal to see the situation of the condition. Dovremmo mettere il retrattore qua. Go. And after we can do a cortical mastectomy. Can we wash the surgical field?
Another retractor, please.
Pure metti qualcosa che solleva lì. Scusa, che cazzo. Ma sì, adesso non vedi che non ci vede un cazzo? Qua? No. No. Okay, we are using 2 retractors. So now the exposition is quite good. And you can see now. No, ragazzi, allora, me lo mettete bene o no? Dai, su. Io manino. We are trying to have a retractor. Ok. No, voglio che stai fermo. Okay, so now we can see bipolar, please. We can see this. This is the ulnar spine. Posterior canal is here. Bipolar, please. Go. And here, of course, you have to detach the muscle. The zygomatic arch is under here. Go. Che cazzo fai? Ma perché mi muovi? So the zygomatic arch is under here. Go. This is the canal that you can see that the canal going this way, in the anterior way. So we are at the finish here of the canal. Can you see? Can you see?
Yes, we can see
okay. So,
the skin reflected over that erosion.
Yes, this is the skin inside the mastoid, you can see.
Yes.
Of the cholestatoma.
Which is
where there is
invaginated, going towards the ADITUS and the posterior eroded canal wall.
Round knife. So
we can see that Professor Marchioni has not done a myectomy. Instead, he's preferred to lift the tympanomeatal flap and straight away go to the eroded part of the posterior canal wall.
Yes, now the situation is bipolar. Now the situation is just to check the condition of the cavity, round knife, and we have to elevate here. And you can see now the retraction.
Yeah, we can see how the skin is actually lining the invagination and the erosion, and how the cholesteroma is being taken inside the antrum.
Yes. So now we can cut here.
Yes.
Blade.
So it's like doing a deep myectomy at the level of the retraction pocket.
At the level of retraction, we can cut like this.
Yes. So that way, Professor Marchioni seems to have saved a lot of canal wall skin, but it's not done meototomy at the level of external auditory meatus, and he's done meototomy at the level of the retraction pocket
Around
itself.
knife.
So do you not think that the skin near the retraction pocket where you have cut will also include some inflamed, infected skin in the flap?
Sorry, I don't understand. So now this is the eardrum, and we need usually something to pass through the external auditory canal.
Yes. Okay.
So now we did this step, so cutting here at the level of the erosion. We can see the eardrum over there, and now we have to put something past the canal. We have a toilet pond. Do you have another one?
Yes.
And now suction, please. And now we have this view. Do you have to wash? Can you see there is the eardrum? The skin of the canal is under the retractor. Bipolar, please. Go. 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 Cotton balls.
Cotton balls.
Okay, so can you see now the situation? This is the first step. Cotton balls. And this is, of course, a microscopic technique. Oh, my glass. Another cotton balls, please. I'm trying to clean just for you. Can we have a cutting drill? And now we can start to drill. We need another retractor. Probably, let me check. We can do it like this. Guarda il monitor, sì, si vede il cazzo qua. Monopolar, please. And we need also a big suction. Big suction. So now we have this anatomy. Sorry, I'm just a little bit in a difficulty because I'm doing everything to see the monitor. So it's like exoscopic approach. Monopolar. This is the tip of the mastoid, this one. This is the external auditory canal, and the zygomatic arch is under here, and the line of the dura is here, the lateral sinus is over there. So now we can start to remove this bone. In order to remove this bone, we always see the landmark, the dura and the lateral assignment. So we can start. Can I have the pedal? Okay. We have to collect bony wax. Mi fai la collezione del bony wax, per favore?
May I have saline? Saline.
Dai, però. E poi prendi una spatolina e un cistellino. Figlio. Now we are we need to collect the bony dust, so we have to wait just a little bit. No, vai un po', che sennò no. Non fa niente, non fa. Israel, but not so. It's cutting, but not too much. Okay, we can try to see, because it's possible to have high speed?
High speed?
Because I think that is not in high speed. High speed.
Speed. Yes. Yes. Okay.
Okay, now is in high speed.
No irrigation now. Yes. No. But
I'm doing this in high speed in order to have some bony dust. You can see that I'm creating bony dust. Non irrigare più. Prendi. Secondo me te ne devi far dare uno più grande qui, cazzo. E poi we are doing always bony dust now. Lava. You can start to see the line of the dura. Okay. This is boring, but it's important if you want to do obliterative technique, if there is the possibility. Serve ancora, eh? Non lavare. Yes, please. Bipolar, please. Bipolar. Togli la mania. Vai. Vai. Questo qua andrebbe sollevato. Togli. Okay, we are collecting again because it's not sufficient. We need probably we can start to see the plane of the dura. Okay. Fermo, togli la mano. Okay. This is the dura. This is the dura. We have to follow in the dura. Stava però molto questo. Cutting, but not so much. I don't know why. It's really difficult to cut. C'è una mezza misura di do you have a smaller drill? Probably it's possible. So this is the line of the dura. Now we are looking for the line of the lateral sinus. Non è controllabile. Non si controlla.
Cosa?
Questa frega.
Sir, we saw that you were collecting the bone dust initially.
Yes.
So to what extent do you collect the bone dust? And perhaps you use it for obliteration of the cavity at later stages. So to what extent of drilling do you collect the bone dust as you are going down into the antrum?
Non ho capito un cazzo. Tu hai capito?
No, non tanto. Perché collezioni la polvere d'osso?
The bone dust possiamo collezionare anche adesso. It's useful if you want to do a obliterative technique. Canal hold down. Devi avere, no, non lavare. Per collezionare la polvere? No.
It seems to us that Professor Marchioni has collected some dust, but presently he is collecting some dust.
I'm doing the collection of the bony dust. Is useful if you want to do canal wall down with obliterative technique.
Now, for the youngsters, I'd just like to share my experience that we collect the bone dust before we do a myototomy. And we have not actually entered into the antrum because the antrum and the canal, both of them are infected.
Yes,
so
of course, but we are outside now. We are not in the antrum, of course. We have to collect before to reach the antrum. You can see that here we are really superficial.
C'è inciso la cute.
And that, ma sì, che scherzo.
Water?
Now we can start to see here the dura, and under here there is the probably the lateral sinus, and now we can go more deeper.
What difference we see in how Professor Marchioni is drilling is actually he is bringing the canal wall, like traditionally we teach, we enter into the antrum, identify the structure, then bring the canal wall down. But the difference that we note here is that Professor Marchioni had been drilling the posterior canal wall simultaneously, and he knows his limit since he has visualized the anterior extent, the lateral extent of the erosion simultaneously. So he is defined the inferior limit till the digastric, till the tip of the mastoid, the superior limit till the root of zygoma, and posteriorly he is waiting for the change in the color of the bone over the sigmoid sinus. As we can see, he has almost approached it. And he is bringing the notable thing is that he is bringing the canal wall down simultaneously. Now, this is very different from the traditional mastectomy approach that we learn right from the post-graduation.
Sorry, now I can try to focus for you, but I just working under the microscope 5 minutes in order to have the right orientation, because with the monitor is not so easy because it's so distant. But just 5 minutes, and after I will return with your focus. Okay. Okay, now I can try to show you the focus. Okay, this is the dura of the middle fossa. This is the orientation of the dura. This is the, we can start to see the sinodural angle and the lateral sinus. Do we have to remove the cotonoid, please? And we are really superficial, of course, and we collected the
we still to enter into the antrum and
so the
visualize the
antrum is here. The antrum is here.
Yes, that's right. So we've reached the upper limit of dissection, that is the middle cranial fossa dura, and the posterior limit, which is the dura over the sigmoid. But we are still to enter into the mastoid antrum.
Yes, we are really superficial now. Before to go deep, we need our lamina. That is the lateral sinus and the dura of the dura of the middle fossa. After this, you can go deeper. But if you don't see the lateral sinus and the dura, is better to avoid, because we must be careful and we must know where is the dura. So now I know that this is the limit of the dura. I can do it here. You can see the dura is here.
Yes, we must note, that all the youngsters should note that the good surgeon always keep on listening and looking at where the site of drilling is, and as Professor Marchioni has pointed out, that we look for the change in color and change in sound of the drill. That tells us where we have the structure underneath have changed. Some important structure has come up.
Bipolar. Go.
We request the audiovisual people in OT that if they can, the audience is requesting that voice from Professor Marchioni's microphone, if that can be increased. Is that possible? Because I think Dr. Verma is there in OT. Dr. Verma, if you can please coordinate this and increase the voice, the volume of Professor Marchioni's microphone.
Now you can start to see the antrum.
Yes, we can see the cholestoma, sir.
Okay, so here we are the antrum. The lateral
Professor
sinus is this
Marconi,
one.
Professor Daniel, we have seen you using, in your previous visits, we have seen you using the piezoelectric drill.
Yes, do you have a
So-
diamond there? Yes?
Yes, do you prefer that piezoelectric drill over this kind of drill that you are using now?
During
Or,
microscopic, no. During microscopic, I'm using traditional drill. During endoscopic, yes, of course.
Okay, so the message is that Professor Daniel prefers to use this conventional drill for the microscopic procedure, and for endoscope he uses the piezoelectric drill.
Can you see the lateral sinus that is here? And this is the sinodural angle. So we can remove a little bit of bone over there.
Sir, we can see that you have started using the diamond polishing burr for this stage.
Yeah, I'm using now the diamond just because I want to do less bleeding for you. But you can see that we have lateral sinus, sinodural angle, and the dura. So it's really important to have this anatomical view before to do the anthrectomy.
So Professor Marconi seems to be, entering into the antrum now, and he's trying to define. Yes, he's following the cholesteatoma, and he's trying to define the sinodural angle right now.
So now
And,
we can try to
yes.
elevate this retraction.
That's true. And he says he prefers to use a diamond at this stage because it gives him, decreases the amount of bleeding.
Give me just 5 minutes to see through the microscope.
Now, as you can see how clearly he could have pulled the cholesteatoma out with the help of grasping forceps or cup forceps. But instead, now I think all youngsters should note this, that he uncapped the cholesteatoma and he is actually dissecting the sac out instead of biting and removing it in piecemeal. So the message, I think, is that we should, it helps you, to dissect. If you dissect the cholesteatoma sac in toto, it helps you prevent the recurrence. Is that right, Professor Marconi?
Yes. It's right. Now I can try to focus here because I'm trying to working to see the monitor, but it's not so easy. We can see the detail now. Let me check if it's possible to. Okay, so you can see that this is the sac. We have to detach. This is the lateral semicircular canal.
That now Professor Daniel has dissected over. This is the place where the suction is the most important landmark. It's the bulge of lateral semicircular canal. And above he is now dissecting the cholesteatoma from the posterior part of the atic, or you can see. You can say the ADITUS as well. And here you will find fossa inquitus where inferiorly.
Cotton ball.
Though I think as we saw the CT scan, the incus was absent in this case.
Also the cotton ball can be used to detach the skin You see now clearly.
It is notable that how carefully, look at this, all cholestoma has to be removed, but still you can see how carefully a good otologic surgeon is actually dissecting out the cholestoma. It has to be, you know, like this. And here he is dissecting it, yes, over the second genu of the facial nerve, that you can see the horizontal portion of the facial nerve becoming apparent.
Cotonoid?
Yes, sir.
Cotonoid again. Round knife?
We request the audience, if there are any questions with Professor Marconi, then you can please come and let us know.
So now we have to detach the skin from the posterior aspect and reaching the tympanic cavity.
No, when
Dr.
Vinicius, we have, when we saw the CT scan initially, the beginning of the case, we couldn't see any of the ossicles. So probably that that DM or the epithelium draped over the promontory, and we couldn't see any ossicles. So there you can see the bent of the facial nerve, the horizontal portion, and the oval window area below that. So probably we don't see any, even the suprastructure of stapes.
Okay, so now we can check. We have to, of course, remove all this bone. Do you have the round knife? And now we need a smaller. There is an adhesion with the promontory region. Okay. Do you have to remove the cotonoids?
Yes.
Now we have to remove this. We need a smaller section. We are inside the tympanic cavity. We need a smaller section. And a cotonoid. You can see this is the promontory region.
So we can see Professor Marconi is dissecting that inflamed mucosa and cholestoma epithelium from the oval window area, and we can very beautifully see under the suction, yes, we can see the stapes footplate right in front of us. And now that the people in the audience were asking that how do you ensure removal from the sinus tympani? So probably it is by drilling and visualization when you are using microscope.
So now the situation is like this. This is the facial nerve, this one. The cochlariform process is here, this one. And the round window niche is over there.
Oval window.
Here.
Yeah, that's the round window niche. Yes.
Sorry, I can try to. Okay. Do you have the curve dissector? The Thomason.
The smaller.
Thomason. So now there is just a scar over there. This one. It's not a cholesteatoma, this is just some tissue.
This is a special angled elevator that we use for endoscopic surgery.
And we can see this is the round window, this one.
Yes, this is the round window niche, and Professor Marconi is clearing the hypertrophied mucosa from it. There might be some adhesions as well.
Yes, in this case, of course, it's not possible to preserve the mucosa because the situation is completely different. Remove the cotton balls. No. Okay, now we have to remove the part of the bone. Drill. Sickle knife. You can see this is the cholesteatoma. Can you see the cholesteatoma now? That was this one. This was the cholesteatoma that was inside here. I remove all this, the sac. These are some adhesion. Okay, so we can see here. Now I try to see the Eustachian tube. So I need the bed more higher.
Up, bed up.
When you are doing this, you can do also obliterative technique because you are sure that all the cholesteatoma is gone because you was able to remove and block and without any okay, stop. Alessia, mi puoi lavare poi ogni tanto perché sennò sickle knife. So this is the normal mucosa. This is normal mucosa, this one. Can we turn the bed
that side, turn.
Professor Marconi, we wanted to know from you that you have not drilled the scutum completely. Are you planning to do it now or you are going to preserve it?
No, in the other side. Di là. I don't understand. Di là. Go.
Have you have not drilled the outer attic wall, the scutum? You plan to drill it now or you will do it later or not at all?
The scutum is ready. After we have to drill here, we have to reduce the wall of the facial nerve, But in this case, you needn't to do too much because we were able to remove and block from here. So it means that you can do obliterative technique. So you can put a bony dust here in order to maintain the posterior canal, and you needn't to do a large hematoplastic. So the plan is like this. This is the Eustachian tube, this one.
Yes, it's the opening of eustachian tube.
Yes,
Where
this is the
Professor
opening,
Balcony
yes.
has put his
The opening
pointer
is good.
is the opening of eustachian tube.
So we can check the situation, and you can see that the eardrum is good. So if I'm able to do obliteration and put the fascia just to cover the obliteration, I have already the canal, and with obliterated technique, and so it's the best. I don't know if you understand my behavior in this case. Okay. Okay. Do you have cotton balls? We can put a cotton balls here, and now we have to drill. Drill. You can see this is the supratubal recess. We have to check just more deep. This is the facial nerve, and this is the cog is over there, and the geniculate ganglion is here under this bone. Drill. Do you have a smaller drill? Smaller. In this case, if you want to do obliterative technique, you needn't to remove too much posterior wall, because the aim is to recreate the posterior wall, and so you can use the actual position of the external canal in order to recreate the posterior wall. It's totally different with respect if you want to do traditional canal wall down. Give me the smaller one. No, this is too big. It's too big. Do you have a smaller? I just remove some cells, but I'm almost okay. Can you see the cog, this one? This is the cog. Can you see? Si vedono? This is the cog, and this is the geniculate ganglion. Okay. Ok? Se io il muro lo lascerei così, perché se facciamo l'obliterativo. E guarda che è abbastanza giovane. Now we are drilling the wall of the facial nerve, but in obliterative technique you don't exaggerate to remove too much bone. Okay. Now I think that could be fine. A sickle knife, because you can see clearly the facial nerve. The cog is here. This is the supra recess between the geniculate ganglia that is here and the cog. The Eustachian tube is over there. The facial nerve turn over there. This is bone over the facial nerve. In the operative technique you can use to reconstruct the canal. You can do this just when you are able to dissect like this, you can see. So you are using this in order to maintain the canal, and you have to separate here the canal.
Now we can see that entire intratympanic course of the facial nerve, the horizontal portion and the vertical portion. That professor has delineated. We can see oval window area and Stiff's footplate area, and how he's just demonstrated.
Yes,
he separated the sac from the entire cavity in toto instead of doing a piecemeal pickup. So that's a wonderful dissection, Professor Daniel.
So now this is, I'm checking the oval window if we want to do a reconstruction of the ossiculary chain. Sickle knife. We can try to use this one.
Yes, there's some mucosal folds over the footplate area.
Yeah, but I feel that the footplate,
Some adhesions, it seems.
it's quite fixed.
Yes, he's trying to clear the adhesions over the footplate to see it clearly. So probably that is going to help in ossicular reconstruction.
Look, there is here.
Yes, we can see that. And
Yeah.
yes, we can even see the movement of the footplate.
Now we can see. This is.
Yes.
So we can try to put something also. Also a bone. We can collect a bone from here. Do we have a small 1 millimeter diamond burr? So my plan now is to sickle knife, please, to reconstruct here the ossicular chain from here, put the fascia, and obliterate this cavity in order to create just a tympanic cavity, well ventilated, and without any huge meatoplastic. Ok. Dov'è? Dove cazzo è il pedale? Dov'è il pedale? Mi dici dov'è il pedale? So we can remove the piece of bone here. Okay, I can try to see the monitor. Okay. Do you have a scalpel?
It seems that you're trying to harvest the cortical bone for a purpose.
Yes, to do a torp prosthesis.
Okay, so you're going to design the prosthesis out of the bone.
How to design? Yes, I have to collect a bone, and after I am doing myself the prosthesis.
Okay.
It's cheaper. Cheaper. In Italy we are poor, so we need to collect bone from the mastoid. But we need a scissor and hammer. Do you have a drill? Just to collect a piece.
Now the advantage of I have published, Professor Daniel, a series of articles in which we have discussed the use of the cortical bone as the total ossicular replacement prosthesis and the partial ossicular replacement prosthesis. We shape them to a kind of umbrella or the mushroom and place it over the stapes footplate. So for the sake of the audience, I just want to mention that keeping the vertical transmission of the sound is always better through the bone, which resembles more like a... And cartilage is more flexible and the conduction of sound is not as good as that of bone. So the cartilage works better as the vault, but for the vertical transmission of sound, the cortical bone is always better.
Now we need the
drill like 2 or 3 millimeters.
grande.
3 millimeters. This is not the drill. Diamond bone.
Big drill. You can see this bone. We have to model. Okay. Do we have? Now we have to modify this bone. That in this way is not so beautiful, but we can try to get more beautiful.
I think Professor Marconi is using the... What size of burr are you using, sir?
This is 3 millimeter.
3 millimeter burr, a diamond burr Professor Marconi is using, and probably he is making a stalk out of, it seems, a stalk out of the cortical bone. He is drilled, and we can see that he has taken the bone from the tip of the mastoid. Any specific preferable site to harvest the bone, sir, for this purpose?
No, just to avoid lateral sinus injury and dura. Forceps. Crocodile. Drill.
Now, what, Professor Daniel, what I am doing in my practice is I drill a hourglass constriction at the upper end of this stalk, and I fit a vault of cartilage in that hourglass constriction.
Yes,
so
it's
it looks
possible.
like an umbrella, we call it an umbrella graft.
It's possible also to use a cartilage.
And I've seen many people,
Section?
they just, keep, a piece of cartilage and supported by gel foam over this.
We can check the situation now. I need a small suction now. Small suction. Small suction. And the sickle knife. Yeah, you can do osteocloplastic also with the cartilage, with synthetic prosthesis. You can do as you please, of course. This was my choice, but it's not. Sickle knife.
So Professor Marconi has, kept, as you can see, the upper part of the prosthesis wide, and the lower part of the prosthesis appears narrow.
Yes, now I'm trying to understand the length.
So one disadvantage, Professor Marconi, I've experienced in such things is that if we have a deep oval window, this prosthesis tends to stick to, the facial bulge, the facial nerve, the ridge of the facial nerve. In the post-operative period causes adhesions and loss of hearing. What is your experience on this?
So sorry, I don't understand. If you put, of course, the prosthesis too narrow, close to the facial nerve, is not good. You need it's really important the length of the prosthesis, sickle knife, and if it's possible, it's better don't touch the bone. So you have to do like this. Can we have less suction, because this suction is too heavy. Okay, so now it's good. Probably is too high. We need to reduce just a little bit. Come si dice che cazzo? Tieni qua per favore. Drill. Okay, so now I think that is better. Suction. Sickle knife. And the gel foam. Careful. My opinion, this oval window is a little bit fixed. No, too big this one. I need small. I feel like the movement of the oval window is not so good because there is probably tympanosclerosis. I don't know.
And the anterior part of Professor Daniel, sir?
Yes?
Yes, sir. Sir, you have dissected that sac.
Yes.
And the sac is there, and you are reconstructing that, doing the oculoplasty. So when you remove this sac, and the second thing is the rest of the tympanic is also plastered. Anterior part is plastered. So do you think that that should be removed and then the further reconstruction should be done along with that oculoplasty?
The drum? I don't understand.
Yes, sir. Drum.
In my opinion,
And the
this
sac,
is...
basically the most important is the sac. There is a cluster of flax in the sac also, sir.
Yeah,
yes.
but you can see, we can remove, but it's a skin. And here, under here is good, it's not so, the skin is here. Here is normal, so I think that was a sac cholestatoma. You know, when go down the skin, but the surface, the medial surface of this sac was not epithelium. So you can maintain this for the reconstruction, and you have to put the fascia under here, Gelfond.
So you're planning to keep the epithelium of the sac over the fascia?
Yeah,
that is going to
because
cover the
this
cavity?
sac,
Is it like that?
this sac is the skin of the external auditory canal. It's not.
Okay, Professor Marchioni, it seems to me that you are saying that you are not going to excise the sac, but you will place it over the fascia that is going to line the cavity. Is that right?
Yes, the situation is different if you open the mastoid and you have not a sac cholestatoma, you have all infiltrated matrix. It's totally different, of course. In this case, was the skin that collapsed down like this, and we were able to dissect in the posterior limit. So you can use this as a scheme of the reconstruction. You have no problem.
Professor, yes, that's right. And this is something very for us, for most of us, it's little unconventional, because anything which invaginates and stores a cholestatoma, we tend to excise it, remove it as a part of the disease. But Professor Marchioni says that it is as good as a skin. And it's an epithelium which can be used to line over the fascia. That's interesting. In fact, it would be...
We are not excising the cavity
No,
also
no,
by
no.
So how it can become normal in later? If there is a aeration in the cavity, then there is a chance of proper epithelialization. Otherwise, no, we are operating with the another tissues now, the same tissue.
Let me sickle knife. Ma perché cazzo lo togli? Dammi, Japan? Perché cazzo lo togli? Sickle knife. Again, we can have different kind of cholestatoma. This was a collapse of the skin. This is not skin. The skin is here. Can you see the difference? Therefore, sickle knife. If you have infiltrative matrix and not sac, the situation is totally different. You are not able to do obliterative technique. It's better to do a traditional canal wall down. You have to remove more bone from the posterior aspect of the facial nerve. We have a bigger one. But this was a pocket, so it's different. Was a large pocket, of course, with erosion of the posterior wall, but was possible to dissect and block.
Sir, when should we excise the cholesteatoma sac and when should we keep it intact? How to decide this?
If it's possible, do you have water? If it's possible to dissect and block and maintaining the sac is the best gift that you can have, because it means that you are removing all the cholesteatoma and the cavity, it's okay, and so you need them to do nothing more. Diamond bar, diamond bar bigger. And of course, wherever is possible. If it's not possible, you have to remove knot and block in a peaceful way, and this means that it's dangerous because you can leave some fragment inside. So no possibility, or it's better don't do obliterative technique. It's a totally different scenario.
Probably, Dr. Pooja, it seems that Professor Daniel is trying to explain that this piece of skin, though it's not what our conventional learning is. Our conventional learning is whatever the retraction pocket is, we have to excise it and we have to, reject it and throw it away. But what Professor is saying, is trying to explain that that entire sac, that the thing that we are calling sac, actually that was continuous with the skin of the canal. And it looked like an epithelialized skin. And he sucked the keratin debris out. So he said that he's sucked the, you can see that, Yes. This is, I agree that this is something unconventional, not as we do it traditionally. Yes. But he said that that epithelium seems to be continuous with the canal skin, and it looks to be okay. The keratin debris he sucked out, the infection he has sucked out, he's irrigated, removed everything. And he says that he'll put fascia to cover the cavity and probably the bone dust that he has harvested. And over the fascia, he'll use this, this epithelium, which we are currently calling a sac. He'll use this as a part of epithelium and this canal wall skin to line over.
Cotton balls.
Yeah, that he uses. I think that's what I can understand out of his explanation.
He was also trying to say that do not remove it completely, remove it in piecemeal or something.
Yes, that's not as like, this is something new for me as well. But then it seems logical and reasonable as well. But
so that it.
Yeah. Yes. Yes, we have Professor
had done in this case.
Yes.
He preserved the skin. Why? Because what you do in the case of 90-year-old patient present with the cholesteatoma and attic, what treatment you should do? You are doing cleaning of that cholesteatoma. Similarly, that side is the skin which is migrated into the mastoid cavity. That's why it preserves this skin. It is not cholesteatoma sac, it is the skin which is migrated to mastoid cavity. Because here automastectomy. In 80 years, 70 years, what you do, suppose due to the medical treatment of cholesteatoma, we just remove that cholesteatoma from the transcanal approach and observe the patient. Similarly, he is doing same thing and reconstruct the area.
But this won't.
See, the problem.
It is the traditional, as Dr. Manu is mentioning, traditional teaching, what we do, we'll wait it and remove it in.
Do you have the fascia?
Elevate from mastoid cavity and remove it. But is different from our opinion.
Sir, it won't cause a cholesteatoma formation later on. बाद में
Cholesteatoma formation lateral. Suppose you have not till the day the whole cavity, but not remove the buttress totally from attic. It will be different from patient to patient.
Okay.
But in this case, is the reconstruction of hearing, remove the bone matrix whole in toto. That is important. But the cholesterol is outside this sac epithelium, and you remove the epithelium.
It means the sac, presence of sac is not going to recur the disease.
Not recur the disease because it is self-cleaning sac. If you see, if it is the intact canal wall and then cholesterol, then he should remove this from the whole mastoid cavity.
The point is that once he has removed that area, that it doesn't look like a sac afterwards. It doesn't remain like a sac. So once it's not a sac, it's only epithelium. So he's retaining the epithelium which was lining the sac. Now the sac doesn't exist. So probably it's a self-draining cavity, a well-sloped cavity that he's going to create after the surgery.
That's why we are doing the medical treatment of cholesterol.
Yeah, agreed. Agreed, sir. Agreed.
Remove this part and reconstruct with the temporalis fascia. What he's doing, sir, is going to use. So what is the harm with that?
Basically, you have to differentiate whether it is a cholesteatoma sac or inward migrated
A sickle knife and the suction
suppose it
is
is he has taken it as a inward migrated epithelium.
What is the benefit with that? That sir has already taken a very good graph. So,
yes,
so it is better than temporalis fascia.
It is kind of natural.
True and exact the lining of that canal. Yes.
Because canal skin is known as 24 karat because it is very helpful for epithelialization. Otherwise, there's a discharge problem from cavity. That's the sole purpose.
So now this is the fascia.
Hello?
Ce l'hai Bonnie Dust.
Daniel sir,
Yes, hello.
we'll be withholding the live telecast for some time for the inauguration ceremony and we'll resume after that, sir.
Okay.
Dr. Tripti here.
Non ho capito niente.
Professor Daniel, that we are all ready in the auditorium for inauguration.
Yes.
We'll stop the transmission for some time.
Okay.
Thank you very much, sir. It was a wonderful demonstration, and
Thank you very much. Thank you.
the entire audience is full of applause for you. Thank you very much.
Thank you.
Good afternoon, all the delegates and the respected faculty members present here. Actually, it is a proud moment for the Department of ENT to conduct an international live surgical workshop, ADITUS 2023, full of all the interesting surgeries, I think not only for the delegates, but for the esteemed faculty members also here. I would,
Avere un cotonino.
let's now seek the blessings of Ma Saraswati
Cotton ball grande.
for the uninterrupted learning lesson here. Thank you.
Uovo ben applegnato.
I would also invite our esteemed guest faculties here, our guest of honor, Dr. HCK Joshi sir, our CMS Brigadier Mittal sir, our principal, Dr. Verma sir, and our vice principal, Dr. Utkarsh sir, Dr. Puneet Ori sir, and Dr. Beg sir, Dr. Pandita sir, and our USAES post holders, Dr. Alok Jain sir, Dr. S.S. Bisht sir, and Dr. Piyush Tripathi sir to please come forward for lamp lighting. Thank you.
हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। तू स्वर की देवी, ये संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। तू स्वर की देवी, ये संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। हम हैं अकेले, हम हैं अधूरे, तेरी शरण में हमें प्यार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। मुनियों ने समझी, गुनियों ने जानी, संतों की भाषा, आगम की वाणी। मुनियों ने समझी, गुनियों ने जानी, संतों की भाषा।
Forceps and electric. I think I can.
Sister, do you have another forceps? Okay.
No, tiri questo. Okay. Suture. Ok. Attento di non muovere troppo.
Com'è?
Di non muovere troppo. Tagliare. Succede? Aspetta. Yeah. Potresti tenermi con un qualcosa, ma no, non vedi che... Ma, cioè, con cosa? Quando c'è il nodo così con un clemerino, no? Vabbè. Non c'è. No, no, cosa fai? Tieni sollevato, per favore. No. Suction. Aspetta. And big gel foam. Oh. Gel foam. Gel foam. Gel foam. Give. This is gel foam. No, no, it's not. Ma ci abbiamo anche del gel foam più grande.
You have a bigger gel foam.
Ok. Again. Other gel foam like this. Voglio dell'altro gel foam. Ok, molla. Tieni qua. Gel foam, big gel foam, big gel foam.
Loro mettono un pezzo di carta.
Vabbè, io no. Gel foam. Ok, vabbè, su tu. Cioè, è stato veramente tribale perché... Yes, ok, thank you very much. It was not easy because I didn't know the same process between the camera and the microscope and the microscope. So sometimes I have to also...
part, if I see here, this is the posterior ethmoid, posterior ethmoid, posterior ethmoid, and this is a small onodi cell here on the right side, which is absent on the left. Can you see this? A small onodi cell on the right side. So these are the only three anatomical things that I wanted to see into this, this CT scan. And if things are ready, then we'll actually now start with the actual surgery.
Okay, sir.
So I am going to use navigation. लगा? इतनी देर से आप लोग क्या कर रहे थे?
Patient has got registered in navigation, sir.
Yeah. हाँ. क्या problem? हाँ. फिर तो ये क्यों नहीं check किया?
Can you?
Do you have another instrument? कौन सा है? ये नहीं चलेगा. कौन सा है? Which has been registered?
This has been registered.
I know that is for registration. Is this working? So give me 2 minutes. You should have not done all this work and kept it ready. No, I would not listen all those excuses. Verification is failing. Can you bring it closer? Listen to me. Can you bring it closer? So they have done the registration, but
right, sir.
But the verification of the instruments is pending. I'm just waiting for the verification to start, because without that I'll not be able to use a navigation.
सर थोड़ा registration के बारे में बता दीजिए.
Okay. कुछ करो ना यार. देखो अगर नहीं होगा तो
there are some resident doctors sitting here, so they should know.
So registration, finally what is the role of navigation? Navigation tells that whatever is the anatomy of the patient on the CT scan should be running with us while we are doing the surgery. So
okay, sir.
The CT scan of the patient is fed into the system. अरे क्या experiment कर रहे हो भाई? I don't listen to all these excuses. You should have kept it ready, na?
So we have been practicing this.
I would not listen to all those excuses. Finally, if your system is not working, I'll operate without a navigation. This is not done. Anyway, so what you do, give me some Savlon. Navigable blade है? Navigable blade लगाओ ना. 12 degree navigable blade लगाओ ना.
12 degree navigable blade.
So you feed the CT scan findings into the system, and on the actual patient, then you register the instrument. And then each instrument that goes inside, the CT scan would run along with the patient. Give me a forceps. I will not waste time. I will not wait. Give me a forceps. Okay. Now see this patient. Are you getting the endoscopic picture? This patient is not actually adequately prepared with the steroids.
Right.
Our idea is to perform ethmoterminectomy. We have to remove all the ethmoids.
So how would you prepare the case?
So this case actually should have received steroids for at least 1 or 2 weeks. Now I'm starting with the surgery. I'll not wait.
Steroids,
Because
what do you use usually?
so it's going to bleed. Are you getting the endoscopic picture?
Yes, we are getting.
Okay, so extensive polyposis. Let me first debride the polyps and get some space. Unfortunately, the navigation system has not yet started.
So what is your protocol for using the steroid?
So I give 2
what
to
do you
3
do?
weeks of steroid, which is betamethasone. My favorite is betamethasone because that
Right,
gives
sir.
the least glucocorticoid and the most glucocorticoid and least mineralocorticoid.
Right.
So least water retention and maximum anti-inflammation. Okay, and I would request the anesthetist to keep the blood pressure as low as possible because navigation is not working, patient has not been prepared with steroids. Only I think 1 day of steroid has been given. So now let us see first after debridement, where is our middle turbinate?
So you use betamethasone, sir, in a constant dose or a tapering dose for 2 weeks?
Yeah, so 1 milligram betamethasone thrice a day for 1 week and twice a day for 1 week before the surgery. That will take away all these polyps out to a great extent, and your surgery will become as much more less bloody. Here it's going to bleed, bleed, bleed and bleed. You understand that?
Right, sir.
So if we wait for the bleeding to stop, we'll not finish off the surgery even by tomorrow. So, and the role of navigation is best in this case, but unfortunately the company, I am not sure if they will be able to provide us with navigation or not. They should have checked everything from beforehand.
Sir, along with this oral steroid, do you prefer using a nasal spray also?
Yeah, you can give nasal spray, but in this kind of thing, there's no place for the nasal spray to work.
Right.
So there's no point. You give whatever you want, but oral steroids are the most important thing that has to be given to the patient before surgery. So this is not the ideal situation for a surgery, but right now we do not have a choice. So I am just debulking first. How is the image quality downstairs?
No, it's good.
So right now I'm just creating some space by debriding, and if the anesthetist can maintain the pulse rate low and the blood pressure low, both the pulse rate and the blood pressure, then we'll be able to demonstrate it nicely. So that's the coena. Now, so these are all polyps. As I said, the middle turbinate was lateralized. Did I say so on the CT scan?
Yes, yes.
And therefore, see, this is the middle turbinate.
Right,
okay?
sir.
It's completely lateralized. Now, if you try to preserve this middle turbinate, your surgery is bound to fail miserably.
I know.
That was, see, there's no point looking at this air cell, that air cell, all those air cells will remove. Whatever is there will remove. But what is the most important thing in this case, that middle turbinate cannot be preserved because it's already lateralized, and the polyps are arising from medial to middle turbinate and huge amount of polyposis. So this will reach the skull base very quickly right now. Let me see, patties please, 2-3 patties. So I've just debulked everything. This is on the septum. The septal mucosa is also polypoidal. Okay, give me some good amount of patties.
So you like to do a partial turbinectomy of middle
Complete. Middle turbinate completely. Middle and superior turbinoplasty almost subtotal.
Right.
That's my technique called ethmoturbinectomy. I have not yet published a paper on that, but I have been talking on this technique for the technique for last 6-7 years now. My total focus has been in sleep apnea, so I have not really been on publication side. But my major work in my practice is nose, sinus is my major work. So now you see.
You do this turbinectomy routinely, sir, or in selected cases?
Sorry?
You do this turbinectomy in
all polyposis cases. All polyposis cases. Because see, in any way, when you operate this patient 3rd, 4th, 5th time, anyway you remove it. Na? So I like to remove it in the first go. So what I'll do is, I'll also go on the left side, do some debulkings and put some patties so that, give me the debrider, so that will save time later on. Right now I'm sure many people would have gone for lunch. So by the time they come back,
people are sitting here, sir, in the auditorium.
Sorry?
People are sitting here in the auditorium.
Oh, they have not gone for lunch?
And then there are few of them.
Few of them, yeah. So I'm just doing the debulking part first.
What do you use in the patty, sir? What solution do you prepare?
So patties is, I think, xylocaine adrenaline. I think in 30 ml I have asked them to put 4 or 5 ml of adrenaline, 6 ml adrenaline, so that
6 ml adrenaline in.
So that helps to decongest nicely, and even if you use pure adrenaline, there is no problem. Even if you use pure adrenaline patties, there is absolutely no problem, because
Excuse me, sir, what about old age patients?
What about?
Old age patients, old patients.
Yeah,
Or
so I mean, if
cardiac
the patient has a cardiac issue, then there is a problem. But otherwise, this does not get absorbed to the extent that the pulse. See, the anesthetist could tell whether the pulse rate has gone even a little higher. I'm sure till now it has not gone higher at all. So with topical adrenaline, the pulse rate would not go high. Only when it is absorbed too much into the system, then the pulse rate will go high. Can you release this microdebrider cable? So I'm just debulking. No point wasting time before debulking the whole thing. So, and unless you are able to see inside, you will not be able to do any kind of surgery. So vision is very, very important. And if the person is just bleeding, then what kind of surgery are we going to be able to be performed?
So like you have been using this technique for last 6 years, you said.
7 to 8 years, yeah.
So what has been your result, like recurrence? Have they been recurrent?
No, so see, at the end of the surgery, you will see that there is nothing else that any revision surgeon can actually perform. So you feel quite, you will stop getting recurrences. See,
And
you will
problem of crusting?
Yeah, nothing. Crusting, how it can happen? Because this is polyposis.
Right.
This is overproduction of mucus. So crusting is never, see, crusting happens when you remove the inferior turbinate. Inferior turbinate in maxilloturbinate. This is ethmoterminal. This is from the ethmoid. So I have done almost complete debulking. Now I think once I do the septoplasty, I'll be able to see the middle turbinate properly. No point wasting time on these things. I'm just creating some space for myself. Okay, give me some patties, please. So now I'll come to the right side because the septum is deviated to the left. So I'll start from the right side. After finishing the right side, then I'll come do a septoplasty, then I'll come to the left. And if anything happening, try the microdebrider pe this navigated blade. Give me some suction, please. Give me some more patties, please. So the first surgery I demonstrated was a bloodless surgery. This is going to be a complete bloody surgery. So that's all right. I mean, the disease is like that, so can't help. Packing forceps. Yes, if you would have treated this patient with 2 weeks of steroid, we would have got a very nice, kind of, not bloodless, but less bloody field.
Yes.
So anyway, so left side I have already debulked, now I have packed. Now we'll go to the right side. Remove this. अच्छा इस पे एक वो लगा के देखो ना, वो चल रहा है क्या? नेविगेटेड ब्लेड चल रहा है क्या? नेविगेटेड ब्लेड भी चल गया तो अपना काम हो जाएगा ना. पैस नेविगेटेड ब्लेड लगाओ ना. चलिए 1-2 पैटीज और रेडी रखिए. ओके, सो गिव मी समथिंग, जो भी रेडी हो. नेविगेटेड ब्लेड देखो, उसको तो रजिस्ट्रेशन की ज़रूरत नहीं है. देखो ये चल रहा है क्या? कहाँ आ रहा है? हाँ, ओके. एटलीस्ट समथिंग इज वर्किंग. थैंक गॉड, एटलीस्ट समथिंग इज वर्किंग. इसका ऊपर करो ना, इसको घुमा के इसको ऊपर करो ना. At least the navigated blade is working, so we'll have something. Kar do lock. Okay, so we have only one navigable blade, 12 degree, which is working. So at least I'll be able to show you something on the navigation. I will keep that I'll try to preserve this blade because we have only one. Are you able to see on the? दिखाओ भाई वो क्यों नहीं आ रहा है अभी? अब क्यों नहीं आ रहा है? अभी तो आ रहा था. Pass लाओ ना. Listen to me. Pass लाओ ना. External camera will show the navigation. External camera.
We are not getting external camera.
Correct. वहाँ रखो. भाई साहब आप पकड़ के नहीं खड़े रहोगे, इसको पास लाओ.
सर PIP करवा दीजिए ना इसको.
भाई PIP external camera PIP please. Don't you understand? I'm telling you again and again. Bring it closer. Will you stand here for the entire period? Then fix it, na. Sorry, brother. You have to cooperate, na. Okay, at least. Okay. Are you able to see the navigation picture?
Yes. Navigation picture is not coming, sir.
Navigation picture, external camera,
Yeah, no,
audio visual.
We get it now.
Can we get a PIP picture
दो
of
दो नहीं है क्या अपने पास? दो सेक्शन नहीं है क्या? So see, are you able to see the navigation picture?
Yes, we are getting the navigation picture.
Are you getting the endoscopic picture?
No, sir.
Arey, audio visual, are you sleeping or you have gone for lunch? Audio visual, are you sleeping or gone for lunch? Audio visual. हाँ? और एक सेक्शन और चाहिए. एक कर्व्ड सेक्शन दे दो, ये वाला लगा दो. लगा, कोई बात नहीं चल रहा तो सेक्शन तो चलेगा ना. इसमें से मत निकालो. Sorry, I have a little situation here.
No, it's fine, sir.
हाँ हाँ, इसमें से मत निकालो ना. मुझे एक एक्स्ट्रा. हाँ तो लो ना दूसरा सेक्शन. I need two sections. One on debrider and one on suction. Correct. It's standard, na? It's standard for any sinus surgery. You require two sections. Okay. So, are you getting both the pictures now?
1 second, sir. No, we're just getting the navigation pictures.
So, somebody, Dr. Verma, can you ask the audio-visual guy to do the needful, na? I cannot handle everything. Audio-visual. अरे audio-visual से कोई नहीं है क्या? वही तो कोई अभी सिंपल सी बात. दो सेक्शन, दो पिक्चर सब चाहिए होता है इसमें. Okay, are you getting the navigation picture now?
We are getting the endoscopic picture right now, sir.
Okay, endoscopic, fine. So no problem. This is the middle turbinate.
Right.
Any confusion?
No confusions.
Okay, but when I put here, the frontal is here. I wanted to show you at the same time.
I know what you mean.
Frontal, ये frontal beak यहाँ पर है. मैं ये दिखाना चाह रहा था.
Yes, sir. Please.
Audio visual, please show ना. अभी क्या दिख रहा है सर आपको?
अभी आपकी सर ये एंडोस्कोपिक पिक्चर आ रही है.
चलिए ठीक है, तो मैं थोड़ा सा ये ना, ये अपना ऑल्फैक्टरी क्लेफ्ट है ये, ठीक है. ये पूरा का पूरा पॉलिप से भरा हुआ है. ये सेप्टम में ऑल्फैक्टरी क्लेफ्ट है. इसको अपने को सीधे सीधे कॉटराइज करना पड़ेगा. सक्शन कॉटरी प्लीज. मैं ये सब काम करके आगे बढ़ता हूँ ना सर. जब तक यहाँ नेविगेशन का रोल नहीं है तो मैं आगे बढ़ता हूँ. चलो सक्शन कॉटरी दे दीजिए.
Now we're getting both.
What are you getting? Oh, you are getting both. Very nice. So सर देखिए, ये मिडिल टर्मिनेट है. और लाइट को बढ़ा सकता है क्या? ये मिडिल टर्मिनेट है. And see where on the navigation I am. So low, right? ये फ्रंटल, ये फ्रंटल.
Perfect now.
Correct. So frontal recess will be here.
Right.
चलिए सक्शन कॉटरी दीजिए ना. मैं इसको कॉटराइज करके आगे बढ़ता हूँ. सक्शन कॉटरी रेडी है? सक्शन कॉटरी प्लीज. नहीं इसमें लगा दो ना. ऐसे टच क्यों कर रहे हो? लगाने वाला नहीं है क्या? टच वाला ही है. चलो ठीक है, टच करो. डोंट पुश इट, टच इट. आपके हाथ में कंट्रोल. नहीं आप टच करके रहो, कंट्रोल में टच में, इट्स ऑल्सो नॉट वर्किंग. व्हाट इज नॉट वर्किंग?
अब चलिए.
क्या नहीं चल रहा है? अरे आप प्रेस मत करो, प्रेस मत करो. चलो शूट. शूट. बस 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 बस. तो सी हियर आई एम बिलो द फ्रंटल बीक. शूट प्लीज. शूट. यहाँ कोई रिस्क नहीं है, स्कल बेस नहीं है ना सर?
राइट सर.
तो मैं पूरा इसको जला डालूंगा बिकॉज ये पॉलीपोसिस है और इसको स्प्रे मिलता रहेगा तो ये काम कंट्रोल में रहेगा. नहीं बस 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 ठीक है. तो यहाँ तो कोई रिस्क नहीं है. शूट.
जी सर.
बस बस बहुत ज्यादा आपका कॉटरी एकदम काला कर रहा है. कॉटरी कम करो, इसको क्लीन करो. ओके एंड नाउ द फर्स्ट थिंग. चलो आप इसको करो, जब तक इसको साफ सफाई करो. मेरे को डिब्राइडर दो. डिब्राइडर में से आप सक्शन मत निकालना भी. हाँ सक्शन मत निकालना मेरे डिब्राइडर से. ओके नाउ सी दिस इज द area of the frontal beak and behind the frontal beak I'll get the frontal recess. That's the normal anatomy. ये middle turbinate तो इतना नीचे है ना सर?
Right.
तो अभी इस middle turbinate को anyway इसके medially polyps हैं, इसके laterally polyps हैं. Can you see that? इसको रख करके कोई फायदा है क्या?
नहीं.
Scissor please. So I'll straight away sacrifice this middle turbinate. Scissor please. मैं पहला काम यही करूंगा कि ये मिडिल टर्मिनेट को पूरा का पूरा
निकाल देंगे.
सैक्रिफाइस कर दूंगा बिल्कुल यहां से. ठीक है.
राइट.
अभी स्कल बेस तो एकदम ऊपर है ना, बहुत दूर है.
जी सर.
नाउ ये काट भी नहीं रही है. इसको मैंने छोटे छोटे पार्ट में कट कर दिया ताकि मैं डिब्राइड कर सकूं.
Okay.
Debrider, please. Now you are seeing the location of this on the CT scan anyways, right?
Right.
ये मैंने मिडिल टर्मिनेट को पूरा साफ कर दिया बिकॉज ये अपने को आगे जिंदगी भर तकलीफ ही देने वाला है. नाउ आइडिया इज कि अपना पूरा इथमो टर्मिनेक्टमी कैसे करें ताकि फ्रंटल रिसेस का एरिया खुला रहे, उसमें स्प्रे जाता रहे.
राइट.
नाउ सी दिस इज द अनसिनेट. ठीक है. एक थोड़ा कुछ दीजिए, सक्शन वक्शन दीजिए, दूसरा सक्शन, कुछ एक अच्छी पैटी वैटी दे दीजिए. अनफॉर्चुनेटली एज आई सेड कि इसमें ब्लीडिंग बहुत होने वाली है एंड वी हैव नो चॉइस बिकॉज इसमें स्टेरॉइड कम दिया हुआ है. दैट्स नॉट अ प्रॉब्लम. नाउ ये अपना बुला आएगा, ये अनसिनेट है एंड दिस इज आवर एरिया विच वी हैव टू कंप्लीटली टेक केयर ऑफ. इफ वी डू नॉट then recurrence is guaranteed.
Dr. Vikas, Dr. Tripti here.
Yes, madam.
So you're doing a commendable job there, and we are able to understand everything here. So don't worry about the bleeding part.
Bleeding part. Thank you.
Explaining, हमको बहुत अच्छे से दिख रहा है यहाँ पे.
Okay, ठीक है madam.
We are able to make out whatever you're showing us.
I wanted to show a bloodless surgery, but in this case it's not possible.
Yes, sir. I understand this is a bit unprepared case. We
कोई
gave
बात नहीं,
steroids
कोई
just for 2 days, but still, sir, we are able to see and make out everything, and that's the beauty of you performing.
Thank you.
Sir, sometimes you have to do in a ready field also, so it's again a lesson for us.
नहीं, because वही डेमो है तो अदरवाइज तो कोई फर्क नहीं पड़ता है. डेमो है, आपको मजा नहीं आएगा, बस इतना ही है. So now this was the middle turbinate. This is the upper part of the uncinate. If I can get a backbiter or something. अरे इसमें
See, our resident doctors who are sitting here, they can also learn that how to do a surgery when it is bleeding.
Yeah, absolutely.
Not to get scared and close the case.
चलिए.
One has to do surgery in every kind of situation.
So now I am going for uncinotomy using a reverse cutting. That's the. कोई बात नहीं. Debrider, please. So that's the uncinate. Now, as you go for the upper part of the uncinate, so that's the axilla, right? ये axilla है तो skull base से एकदम ही दूर है. आप navigation पे देख रहे हैं ना कहाँ है? Are you able to see on the navigation where I am operating? मैडम आपको वो दिख रहा है क्या साथ में?
हाँ बिल्कुल दिख रहा है सर.
Okay. So this is what I wanted to show. Now see, that's the axilla.
Right.
I am opening up the axilla completely here, and I am absolutely away from the skull base. So यहाँ पे skull base आता नहीं है, and now I am reaching the behind the axilla, and this is the upper part of the uncinate. So this is our agar-nazi cell. So I have removed the agar-nazi cell, and I'll remove all the cells below the frontal beak. Right, so that's the middle turbinate, attachment of the middle turbinate. I have removed the attachment of the middle turbinate. This is all muck. So everything below the frontal beak I'll remove, and here there is absolutely no risk because I am below the frontal beak. I am away from the skull base. Are you able to see, sir, where I am working? So ये यहाँ पे कुछ आता ही नहीं है और हम कितना डर रहे होते हैं इससे. ठीक है. So now this is all polypoidal. एक थोड़ा सा पैटी दे दीजिए. छोटा सा एक वेसल है, कोई बात नहीं, बहुत छोटा सा है. पैटी दे दीजिए. सक्शन पैटी. 2 मिनट के लिए पैटी रख करके वेट कर लेंगे. सो अपने को आर्टरी कौन सी ध्यान में रखनी है? एंट्री एथमोइडल आर्टरी. इसके अलावा कोई आर्टरी पे दिमाग नहीं लगाने की जरूरत है. इधर और कुछ छोटी मोटी एथमोइडल की जो भी ब्रांचेज आएंगी उसको हम लोग कोएगुलेट करके आगे बढ़ सकते हैं. एंट्री एथमोइडल अभी आ ही नहीं सकती है बिकॉज अभी तो मैं बहुत आगे हूं. अभी तो मैंने बुल्ला खोला ही नहीं है. राइट, तो कोई बड़ी आर्टरी आ ही नहीं सकती है. नाउ ये छोटा बोन चिप जो है, कैन यू गिव मी सम अपवर्ड और समथिंग टू टेक ऑफ दिस बोन चिप? अपवर्ड प्लीज, अपवर्ड. ये पूरी जगह बन जाएगी. अभी कोई पॉइंट ही नहीं है यहाँ पे मिडिल टर्मिनेट को बचा करके रिसेस में काम करते रहने का, बिकॉज मिडिल टर्मिनेट विल नॉट लेट यू, द स्प्रे विल नेवर रीच इनसाइड. सो माय फर्स्ट स्टेप इज रिमूवल इन सच काइंड ऑफ पॉलीपोसिस. फर्स्ट स्टेप इज रिमूवल ऑफ द मिडिल टर्मिनेट. नाउ द बुल्ला इज इन फ्रंट ऑफ अस. गिव मी द नेविगेटेड डिब्राइडर प्लीज. Let us see what is that area. क्लीन तो करके दो कम से कम. दे दो ना. Now see where we are. We are still much. ये दिखाओ जरा. सजाइटल दिखाओ. सजाइटल ये वाला. सर देखिए मैं कहाँ हूं अभी. डॉक्टर तृप्ति. कोई नहीं नीचे.
Yes, Dr. Vikas. नहीं, we are there. We are very much there.
नहीं तो मैं ये बोले, see this is where I am. Can you see on the sagittal? I am just behind the frontal beak. Frontal beak के पीछे frontal recess, right? It is.
Okay. Yes.
Right, on the sagittal you can see.
Yeah. Now we can make out. Yeah.
Correct. Now give me a suction. सक्शन ये लगा करके दो. ये इसमें ही लगा करके रखो. स्ट्रेट में मत लगाओ, इसमें लगा दो. इसमें लगा दो ना सक्शन. सो यू आर ऑलवेज एकदम कांस्टेंट लैंडमार्क है फ्रंटल के लिए.
जी सर.
बिहाइंड द फ्रंटल बीक. तो दैट्स द फ्रंटल बीक एंड बिहाइंड द फ्रंटल बीक. इसमें ऊपर जाएंगे तो फ्रंटल खुलेगा. इसके हम ऊपर जाएंगे तो फ्रंटल खुलेगा. एंड सी आई हैव वॉक्ड इनटू द फ्रंटल. ठीक है सर, एकदम क्लियर.
परफेक्ट.
एकदम पूरा अंदर से. आई एम वॉकिंग इनसाइड.
लवली.
ये फ्रंटल साइनस का ये फ्रंटल रिसेस है बिहाइंड द फ्रंटल बीक. इट्स द मोस्ट कांस्टेंट लैंडमार्क. और कौन सा एंगल हम लोग यूज कर रहे हैं? 0. We are only using a 0 degree, right?
Yes, sir, and very nicely seen with 0 degree.
So 70 degree, ये वो बहुत confusing है.
Yes, you were telling me this yesterday.
Yes.
That you will be showing every sinus with 0 degree only.
Now see,
So,
with a
now
0
we are
degree.
witnessing it.
Your suction is angled, sir?
No, हाँ, suction was angled. Actually, अगर उसका navigation चलता ना, तो मैं आपको एकदम उसका वो अंदर जाता हुआ दिखाता. अभी मैं आपको 70 डिग्री लेकर के एटलीस्ट साइनस दिखा दूंगा. So now see, the whole frontal recess is widely opened. और अपना स्प्रे तो यहाँ तक पहुँच जाएगा ना.
हाँ जी सर.
एक पैटी दे दीजिए ना थोड़ा. Okay, can you see the inside of the frontal sinus?
Yes, yes.
That's the frontal recess area. Obviously, the inside of the frontal sinus, you will be only able to. Curved debrider मिलेगा क्या? कोई 40, 60 curved कुछ मिलेगा?
Can you comment on the position of anterior ethmoidal artery at this place?
अभी एंटी एथमोइडल आर्टरी का सवाल ही नहीं है ना. अभी तो हम लोग फ्रंटल के आगे हैं. मतलब अभी तो बुला खोला ही नहीं है. अभी बुला खोला ही नहीं है, तो अभी कहाँ एंटर एथमोइडल आर्टरी? मेरे को एक सक्शन दीजिए ना. कोई अच्छा डिब्राइडर खोलना ब्रदर. कर्व डिब्राइडर. Okay, anybody has any questions regarding whether it could be frontal or not? Unfortunately, इनका जो ये दिख नहीं रहा है. 70 डिग्री स्कोप दो, मैं अंदर एक डाल करके दिखा देता हूँ. 70 डिग्री स्कोप दे दो. ये क्या है? So now this is the frontal beak. Frontal beak के सामने छोटी मोटी जो सेल है मैं उसको भी निकाल दूंगा. बीक के ऊपर कभी भी पॉलिप्स नहीं बनेगा. ये जो छोटा सा बचा हुआ है इसको निकाल जला करके छोड़ देंगे. So now the spray will always reach the frontal recess area.
Yes.
एक कर्व डिवाइडर दो ना. हाँ. और एक 70 डिग्री स्कोप दे दो, बिकॉज आपका ये चल ही नहीं रहा है. ओके, कैन यू सी दैट?
राइट सर.
ये मैंने पूरा म्यूकोजलाइज छोड़ दिया है. अब 0 डिग्री से यू कैन सी इनसाइड.
Very nicely, sir.
चलो, ये पूरा देखिए मैडम कितना अंदर गया है. कैन यू सी दैट? होल थिंग इज इनसाइड. इसके अंदर से हम लोग पूरा ये निकाल देते हैं.
ये पूरा पॉलिप. यस सर.
हाँ, पूरा ये जो म्यूकस है पूरा निकाल देते हैं. एक वॉश मिलेगा तो वॉश दे दीजिए. एक अच्छा वॉश दे देते हैं. अभी अगर डिब्राइड आपके पास ये चल रहा होता ना तो वी कुड हैव शोन इनसाइड ऑफ द फ्रंटल. क्या है क्या है? नहीं नहीं, हाउ कैन यू गिव वॉश? आई विल गिव वॉश इनसाइड द फ्रंटल ना. ये क्लीन करना बेटा, क्लीन कर दो ना. एक अच्छे से इसको क्लीन कर दो. क्लीन कर दो. नहीं, स्कोप को क्लीन कर दो. स्कोप. एक सेकेंड. ओके, सो ऑल
म्यूकस
सक्शन चल नहीं रहा है आपका. सक्शन. चलो कुछ तो दो चलता हुआ. Sorry, my patience. I'm losing on patience because as
I would request the OT floor team to please take care of the suction. Why is sir complaining of suction not working
okay,
time
madam.
and time again?
So that's inside the frontal.
OT team take care.
Okay, so that's the inside of the frontal.
Is there.
With a 0 degree, you are able to see inside, and it's completely mucosalized. So this will possibly never close down. Okay.
Yes, sir.
Okay.
This was the mucus which came out of frontal.
Yes, sir.
Now we'll go for our maxillary. So I think even if we are able to show one side properly, na, now this was the lower part of the uncinate. Okay. So I would go inside the maxilla with a suction, curved suction, and this is the lower part of the uncinate. Give me the debrider. The mucosa of the maxilla is getting pulled, so I do not want that. What kind of debrider you have?
So 60 degrees.
Okay, whatever. So I'll open up the maxilla from here. Sorry. Actually, it's, so that's the maxillary ostium's opening.
Bulla is still intact, no?
Bulla is still intact. So long back, I think, give me upward forceps. Long back in 2000 or 2001, Professor Dharamveer Sethi from Singapore. So I had learned the intact bulla technique from him.
Okay.
So 23 years back. So since that time I have been following that. Now see, the natural ostium is here. The natural ostium is here, it's not here. This is the posterior fontanelle. Natural ostium is still here. So I'll take a debrider and I'll open up and connect both. Okay. So we'll not waste time on. So can you give me a backbiting or something? So we have to make sure that we do not damage the inside mucosa of the maxilla.
So just enlarge the ostium.
Yeah, but the natural ostium is still not connected because of this small. Can you give me a backbiting? What? Alright, it's opening on this side. So I'll try to go in and take out this.
Uncinate?
Yeah, part of the uncinate. Lower part, no, it's not reaching. It's not reaching there. A little longer वाला नहीं है ना? चलो कोई नहीं. ठीक है, पहुंच जाएगा तो ठीक है, नहीं तो कोई बात नहीं. A little bit of bone is still there. I am not very happy with this.
Can you use that reverse curate, sir?
Yeah. Do you have a reverse curate? That is the best instrument to have. 135-degree reverse curate if you have. नहीं है ना? कौन सा curate है आपके पास? कोई भी curate है तो दे दीजिए. See this small piece of bone, I would be happy to remove this. Okay, I'll not waste time. Now let's go for the ethmoidectomy. मिल जाएगा तो दे देना. Okay, so now we'll go for the ethmoidectomy and see how much space you have the moment you remove the middle turbinate.
I know.
You are not operating in a small recess. कौन सा curate है? चलिए अब 0 degree या कोई straight 0 degree straight blade, non-navigated 0 degree straight blade, please. So I am just breaking up the septa in the. See, I am not pulling out any septa. I have not pulled out a single. अरे इतना time लगाओगे brother? क्या कर रहा है? 0 degree लगा ना फटाफट. So I have not pulled out a single bulla cell. I just broken all the septa, and then I will take the micro debrider and simply
For
eat
all our
away.
MBBS students sitting here,
Yeah.
sir is doing a case of sinonasal polyposis.
It's looking very
Bilateral
bad.
model polyps are there, and see how beautifully he is removing and making space here, excentrating all the ear cells, and
क्या हो गया? छोड़ दे जाने
this
दो.
is his technique of ethmoturbinectomy. I say, sir, am I right?
Yes, yes,
Vikas, sir?
madam. Yes. So now this is the middle turbinate. I again blocked. Okay.
Yes, sir.
So no point keeping all this. If you keep this, this will keep troubling you. So I'll completely exenterate the middle turbinate. So this must be looking very horrible to. What is that? What is that? What is that?
Blood clot.
Give me a suction, please. What was that blue thing inside? No, give me a straight suction. Give me a straight suction. There's something inside. कुछ टूट के गया है क्या? So, students, please do not get bothered by the bleeding. What is this?
Yes, rightly sir said.
What is this?
Oh, that looks like a foreign body, a metallic piece or something.
Okay.
डिब्राइडर का
डिब्राइडर का नहीं है सर, ये कुछ पेशेंट के नाक में था पहले से.
अच्छा. नोज पे समथिंग
कुछ maybe I don't know, whatever.
फीमेल पेशेंट सर?
Male
patient.
Male patient.
Okay, so see, this is polyp, this is middle turbinate, that's the maxilla opened up, that's the frontal, and this is the upper part of the uncinate ethmoids. I'll take off. This is the septum. Now, all these are polyposis. Okay, give me a 0 degree straight forceps, the debrider. सक्शन ही नहीं चल रहा है डिब्राइडर का. सक्शन नहीं चलेगा तो कैसे काम करेंगे ब्रदर? See, you have to give me a working suction ना. तो चालू करो ना प्लीज. क्या फायदा ना. अच्छा, for students, the moment we complete this surgery, a whole bleeding will just vanish.
Yes.
They have to know that it's looking so full of blood, but the moment we complete our surgery, कोई चलता हुआ सक्शन दे दो ना. डिब्राइडर का ब्लेड क्या है आपके पास अभी? चलता हुआ क्या है? नेविगेबल ब्लेड दे दो. चलो जो है आपके पास, जो चलता हुआ है वो दे दो. So okay, since the 0 degree is not ready, I will use the navigable blade 12 degree to show you the skull base now. Now we'll go, so front, is this working? Is this working? Okay. So are you able to see the navigation now?
Yes, sir.
Okay, so behind the frontal, this is the area where the skull base curves. Right. And this is the area where we typically leave behind air cells, because we are pretty close to the anterior ethmoidal artery and the skull base. Now see where I am. This is the area.
Yes.
Right? So I am behind the frontal, but ahead of the anterior ethmoidal artery. This is the area, right?
Yeah.
So now I will remove all these air cells under navigation guidance. So see, now I am going in a territory where one mistake can lead to a disaster. Okay. Upward,
Yes,
please. Upward forceps. So I want to take off all these air cells. Shall we debrider, please? Okay, see, that is the skull base there. That is the skull base.
Yes, sir.
Right.
Suction, please. Now here we have to be very, very careful, because the skull base is, can you bring that closer to me? Madam.
Yes, sir.
In the auditorium, what all navigation, what all pictures are you getting? Only
Sagittal.
Cornal, sagittal.
So we're getting cornal, axial, sagittal.
Oh, all the three. Are you able to see?
Sir.
Are you able to see that I am still behind the skull base on the sagittal? See.
Yes, sir.
We
can see.
I am still away from the skull base.
Yes.
Slightly lower to it.
Slightly lower. Now, if the navigation is correct, then I should go a little more high.
Yes,
Right.
But if the navigation fools me, then I'll be inside the brain.
That's a problem.
So I will take my time. So see, the whole frontal recess area is completely cleared, but the anterior ethmoidal artery should be somewhere
Here.
Somewhere one cell behind, so it should be somewhere here. Now I have seen on this CT scan that the entorthmoidal artery is not hanging.
Right.
That gives me a comfort that I can debride in this area.
Yes.
But here I would have appreciated if I would have been able to see little better. So this is exactly the area of the entorthmoidal artery. Patty. Patty, please. और अनफॉर्चुनेटली अपने पास सिर्फ ये नेविगेटेड सक्शन नहीं चल रहा है ना अपना. यस सर, क्या बोल
When
रहे
you
हो?
say
करके रखना
clearly,
है.
you mean less of bleeding.
Yeah, and unfortunately I only have a 12-degree debrider blade. See, the blade is not that accurate. The navigated instruments are much more accurate. Blade has very big tip. Can you see this? So it will
Yes,
not
yes.
give me sub-millimeter or that kind of accuracy. So I cannot risk the entorthmoidal artery with this accuracy. But if I had a frontal seeker or a upward curved suction, that would have given me quite a bit of accuracy. लेकिन वो चल थोड़ा ना रहा है, नेविगेशन थोड़ा ना चल रहा है उसका, नेविगेशन थोड़ा ना चल रहा है. चलो कोई नहीं, ठीक है ना, जो आपको व्हाट्सएप प्लीज. अच्छा, एक छोटी सी और एडवाइस है इसका ना, ये थोड़ा धागा लंबा रखिए, तो धागा बाहर रहता है ना, तो उतना व्हाट्सएप की जरूरत नहीं पड़ती है. Okay, so we'll let the bleeding settle down and then proceed in this area, because we do not want to. Now what is this? This is all polyposis. This is all polyposis, and that's the middle turbinate. So till that time, let me just complete this work. Blocked. Give me a scissors till that time. Scissors. So let me remove this. Hana, just clean it, clean it. It's blocked. So let me just cut it off so that I am able to debride it and remove it. चलो कोई भी चलता हुआ दो ना, 0 डिग्री दो ना, 0 डिग्री अभी. So normally we take around 45 minutes for one side at the most. Here I am little slow because of various reasons, but that doesn't matter in the life of the patient. चल नहीं रहा है, ब्लॉक है, सक्शन ब्लॉक है. इसको क्लीन करो ना ब्रदर मेरे. इसको क्लीन करने के लिए नहीं है क्या आपके पास? इसके लिए क्लीन करने के लिए नहीं नहीं ब्रश होती है ना. चलो 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 चलो. Now for students who are watching this and they must be thinking what I am struggling, at the end of the procedure now we'll have an extremely good result. This patient
Yes,
will have
good afternoon, Dr. Vikas. This is Dr. Manu here from the hall.
Yeah.
And we are seeing how you're resecting in the region of the axilla. You are resecting, it seems to me, the middle turbinate.
Yeah.
And the polypoidal tissue.
Unfortunately, the suction is not working. Do you have a stronger suction? No, na?
Do you always like to use the debrider to remove the uncinate process?
Sorry, come again?
Dr. Vikas, do you always like to remove the uncinate process with the debrider, or you like to use different?
No, ideally a beginner should never use a debrider to remove the uncinate.
Particularly in the lateral wall.
Correct. You are absolutely correct. But here with so much of bleeding, you will.
Yes.
So and I was very sure that obviously my blade was directed parallel to the orbit. Now see, this is the orbital wall.
Very true.
My blade was directed parallel to the orbit.
Yeah, the key is for the beginners is, as Dr. Vikas is saying, that one should be working parallel to the lateral wall and never towards it.
Yeah, and this is not a typical demo, honestly. After 24 years of doing sinus surgery, I am taking liberty. No, this is not working. Give me something which is working. Come on. After 24 years of no suction is working. I need something which is working. Nah? Otherwise, see, surgery khatam hi nahi hogi.
Debrider, we need a stronger suction.
कुछ तो चलता हुआ दो ना सक्शन. आप 12 डिग्री वाला डिब्राइडर दे दो, वो तो कम से कम चल रहा था. Fine. So I have taken few liberties. Please, youngsters should not take those liberties when they are starting. So all this requires a micro debrider. You cannot. एक चलता हुआ डिब्राइडर दे देना भाई. जो चलता है वो दे दो. जो चलता है वो दे दो. I can manage with anything which works.
Idea with the debrider is that you should let tissues get sucked in and then you should bite.
So now we will get the superior turbinate. See, this is the middle turbinate, right? This is the remnant of the middle turbinate.
Yes.
So obviously this middle turbinate is of no use. I am going to debride it. But behind the middle turbinate, here you will get the superior turbinate. I am removing all these air cells. I am pretty down, so I am not using navigation. Okay, I think this is navigated blade. You are able to see where I am working, right?
Right.
Okay, perfect. So now
Dr.
that's
Vikas, what is your take on preserving the middle turbinate? At least
no, not in this case. Not at all in this case. Complete removal. See what I am doing. I am removing it completely. Now I am very close to the skull base. Because see,
how do you decide whether the middle turbinate has to be completely removed?
No, such kind of polyposis, this is a disease of the ethmoterminal, na?
Right.
This is, you can see it's completely polypoidal here.
Yes.
Polyps are arising from medial to the middle turbinate. So if you preserve it, you will never be able to deliver a spray later on. Because this is not a surgery, clean it, blocked. Surgery we are doing only because we cannot treat this patient medically, and this is a medical disease. So our aim of surgery is only to give delivery of nasal spray. Okay, and can you see how nice the skull base is? Can you see any polypoidal change on the skull base? No.
Yes, we can see that.
Polypoidal changes are only on these air cells, right?
Yes.
Therefore, you have to remove the ethmoids, and you have to. Can you see how nice the skull base is and clean without steroids? So unless you remove all these ethmoid air cells, what is working? Debrider. Okay, 0 degree, no problem. Thank you. Now you see, the moment you remove all these air cells, the diseased mucosa is gone and the bleeding has also become less. Do you appreciate it? So the disease is in mesoderm. Mesoderm, ethmoterminal is a derivative of mesoderm, and skull base is a derivative of ectoderm. So problem is not with the ectoderm, problem is with the mesoderm. That's simple embryology. Therefore, I have to remove all the structures which are derived from the mesoderm, not which are derived from the ectoderm. Okay. Now see, that's the skull base, that's the skull base. This is the area of the anterethmoidal artery. I'll try to show you on navigation. Give me the navigated blade. Keep it ready. Let me finish. This blade is working. So my surgery on the right side is almost over. Only part pending is the middle turbinate here. And this is the superior turbinate. This is the septum. Can you see polyps arising from septal mucosa here?
Yes. The septal mucosa is
also arising.
Yes.
So
Dr. Vikas, how do you advise the students to localize and be cautious at the area of anterior ethmoidal artery.
Anterior ethmoidal artery, yes. I'll just come to that. Let me finish. This is the superior turbinate. Okay? Sure. So I am removing the whole superior turbinate because you can see it's also completely polypoidal. And here I am pretty close to the skull base. Okay?
Now since, yes.
Let me first...
Since superior turbinate is also one of the landmarks for localizing the opening of sphenoid sinus.
Yeah, I'll just go to the sphenoid ostium after this.
Yes. Do you like to localize the sphenoid sinus first before removing the...
How you will be able... This is the sphenoid sinus ostium.
Right.
So, sphenoid sinus ostium is 1.5 centimeters above the choana. That's a very constant landmark.
Yes.
So it has to be here.
Yes.
Okay.
1.5 centimeters above the arch of choana.
Correct.
And just behind the posterior end of the superior.
Correct. Now, as I said, this is the onodi cell. I showed you the small onodi on the right side on the CT scan. This is that onodi cell. So where is the optic nerve? You will see the optic nerve in the onodi cell.
Medial to, medial to the cell, we can see the optic nerve.
That is the location of the optic nerve. This is the location of the optic nerve. Can you give me the navigated blade?
Right.
Give me the navigated blade. Are you able to see? That's the optic nerve.
Yes, we can see that. Yes.
That's the optic nerve. Okay.
That's right.
That's the optic nerve. So I know that there's a onodi on the right side. So I'll not go lateral over there. And now I will only remove the दो ना जो चल रहा है वो दो ना कुछ तो चलता हुआ दो भाई. So that's the onodi cell. That's the optic nerve.
Yes.
And all this is the superior turbinate. I have removed this small part of the middle turbinate which is pending, also should be removed. I want to just chop it from here because this is of no use. And now see, I will get the sphenoid sinus ostium here. So let me remove all this, and then I am using a navigated blade now so that you will be able to see. On the navigation you will be able to see where I am. That's the superior turbinate. Can you see it's polypoidal?
Yes, very much.
So removal of the superior turbinate almost completely. That's the septum. And can you see on the sagittal where I am? I am right on. Sir, can you see on the sagittal? It's right on the sphenoid.
Yes.
Now if I have to, yeah, if I have to widen this sphenoid, that's the sphenoid ostium. I'll show you the sphenoid ostium without damaging it. Can you give me a patty?
Yeah, we can very much see the sphenoid ostium.
Yeah, there's a lot of bleeding over there. Patty. So if you want, you may not widen this sphenoid because there is no disease inside this sphenoid. But why I want to remove all the obstruction from the sphenoid ostium area, sphenoid ethmoidal recess, because that part of the mucosa is ethmoid in origin.
Yes, that's right.
And
Dr.
that will
Vikas,
keep on.
in our practice, we are using a lot of warm saline when we are doing skull base for irrigation, and that
yeah, you can use it. I have no objection. If it helps you, use it. I fail to understand why warm saline will help. See, for hemostasis, if you use cold saline, it will help. Now see, the whole skull base is in front of you, right from frontal to sphenoid with a 0 degree. I wanted to show you the sphenoid ostium, but still it's not decongested completely. I want to take off this. Can you give me the sphenoid punch, please? Straight sphenoid punch. Now you see this part of the, I will try to open up the sphenoid ostium laterally.
So
Okay.
that is the kerosene sponge you are
Kerosene
using.
sponge, yes.
Okay.
So the bone was
So
pretty
Dr.
thick.
Vikas is widening the sphenoid ostia laterally.
Yes.
It should be noted that he is not widening it inferiorly, because inferiorly the mucosa contains the branch from the sphenopalatine artery. Is
Yes.
that right, Dr. Vikas?
Absolutely correct. Now can you see the polypoidal tissue here? That's why our thing was
Yes.
not seen. ये block है, इसको खोल करके दो. So now everybody would have appreciated that the bleeding is almost stopped automatically.
Yes, once you get rid of that, yes, mucosa.
Now I
that
want to
poly-
debride this.
Yes.
That's the sphenoid ostium. So I have got a 0 degree which is working, so I'll use that, not a problem. Here again you have to be very, very cautious because you are on the sphenoid. So anterior wall of the sphenoid does not contain anything. Correct?
True.
Okay, can you see the sphenoid? There is no pathology inside the sphenoid. This is the wall of the ethmoid. The anterior wall of the sphenoid is made up of ethmoidal. Therefore, you widen and remove this. Got it? So now my sphenoid ostium is widely opened, and I have protected this branch which can bleed horribly. And anyway, if this branch is preserved, Haddard flap can be used sometime by a later surgeon if there is any skull-based
Yes.
tumor
So
or
that-
CSF or whatever.
Yes, very true that Dr. Vikas, septal branch of the sphenopalatine artery
Forcep.
passes just beneath, under the opening of the sphenoid sinus, and Haddard flap is based on
Suction
that
cautery
septal
ready.
branch.
Okay, now the only thing pending for me is this middle turbinate, which is still pretty
Posterior end
large.
of the middle turbinate.
Posterior end of the middle turbinate, which is still pretty large. So I'll just trim it and touch it with a suction cautery, because there is a small supply which can later bleed sometimes.
Contains,
So see, I have not
branches
gone. I have not gone till here. I have just preserved a little bit of it so that when I do the suction cautery, there is some soft tissue. So my surgery on the right side is complete. I'll show you all the structures. How are you placed in terms of time? Cautery touch.
You're
Touch,
perfectly on
touch.
time.
So see this small end part of the middle tub, बस touch it. Cautery तो एकदम बस जला के राख कर दे रही है. So the okay, touch it, touch it, touch it. No, touch it. Thank you. So that it does not bleed later on. Now let us see if there are any bony chips I like to remove. So on the navigation, I like to show you all the structures once. Give me the navigation. That is inside of sphenoid. Obviously, you will not see the carotid artery and the optic nerve because you have an ONOD situation on the right side. In this case, we need not do anything to the inferior turbinate because we have chopped off the middle and the superior turbinate completely. Now, my question to the audience is, if this patient, first of all, the recurrence will be quite less, but if he gets a recurrence, what revision surgery can be performed? Anybody would do any revision in this case?
No, I think you have widely opened all the channels. The cells are gone now, and even the middle turbinate is gone.
Yeah, so there is nothing
I
left for a
think
revision
it's
surgery. चलिए डिवाइडर ये वाला.
Yes, but if you are carefully using steroid sprays and conservative
Correct.
treatment,
Now see,
I
this
don't
is
think
the
patient should have.
correct. So
Yes.
this is the skull base. See on the navigation. Nothing
That's
left.
right.
Nothing left.
Yes.
Nothing left. Whole skull base is seen. That's the posterior ethmoidal artery. This is the anterior ethmoidal artery.
Yes.
This is the area ahead of the anterior ethmoidal artery. This is the area where we had the frontal. recess.
Yes, that's right.
Now there is absolutely nothing left. What you can at the most do is you can cauterize this area a little more if you want, because this is all polypoidal.
Yes.
Yeah, suction cautery.
What I was saying is, like, in our practice, we'd like to leave a little bit of axilla as a landmark if the revision surgery would be required.
Yeah, so see, if I would have left the axilla, na, this whole frontal thing would not have been identified, and the spray would have to go from at 70-degree angle. Spray cannot reach, na.
Have you performed a kind of draft procedure in this?
So this is a draft 1 only, na. So what I have done is a draft 1.
Right, right.
This is nothing but draft 1.
Yes, that's right.
Correct. एक upward suction दे दीजिए खाली. Upward suction.
So draft 1 here means that the frontal sinus ostia has been widened.
See,
anteriorly.
See, there is a little bit of polypoidal tissue in the frontal recess area.
Yes. Yes, that's right.
Can you see
And
that?
it is the attachment to
So
middle
if I now
so
take away the frontal beak,
yes.
so there is no need, because see, this is the frontal recess. This is
No, it's wide open. There's
correct.
no need. Absolutely.
There's no need.
Yes.
वो spray जाएगा ना उसके अंदर.
Right.
ठीक है सर. So now let me go for septoplasty. कुछ दीजिए inject करने के लिए. Whatever you want to give for injection. Xylocaine, adrenaline. Okay. So septoplasty, I do not want to take too much of time, but obviously थोड़ा समय तो लग ही जाएगा. So I am infiltrating with saline, adrenaline, or whatever has been given to me.
One point we have noted that you have not gone for the septal correction in the initial phases.
No, but I'll go now, because left side I have to work ना. अरे कुछ पैटे दो ना, पैटे निकालने के लिए तो कुछ दो.
There is one more point. If we raise the mucoperichondral flap while we are started the surgery, it keeps on falling on the suction.
That is the reason. That is the reason.
Yes.
Absolutely.
The surgeon throughout the
Absolutely. That's the reason I did not do anything beforehand. I only debrided. और ये करके रख दिया ताकि जब भी अभी इधर आएंगे तो थोड़ा कम टाइम लगे.
Right. That's wonderfully thought, Dr. Vikas.
Thank you. चलिए अभी इसमें कौन हेल्प करेगा मेरी? चलिए नाइफ. Now it's a grossly deviated septum. और ये देने के लिए कुछ तो दीजिए.
We should inject, and beginners should appreciate the fact that how blanching and ballooning of the mucoperichondrium is being done while Dr. Vikas is injecting the flap. And this is the Freyr's incision is giving at the anterior end of the septum, cartilage.
And this has to be in the skin and not on the mucosa.
Right.
Because if you give it on the mucosa, the whole flap will tear. अब आपके पास क्या है इसको पकड़ने के लिए क्या देते हैं आप? और कुछ पेरियोस्टम एलिवेटर तो दो. कैसे उठाऊं? सक्शन करो भाई. चलो दिखाओ. एंडोस्कोप दिखाओ. ब्रदर एंडोस्कोप दिखाओ ना. किधर गया इंसिजन अपना? कहाँ गया इंसिजन?
So if the audience can appreciate this fact, that it seems to me that now the surgeon is not holding the endoscope.
Yeah.
And he is using both of his hands. One of the hands is holding the forceps, the other is dissecting into the flap.
चलिए वो अपना वो वाला दे दीजिए. दूसरा वाला. नहीं. एलिवेटर. इसको पकड़ो. हाँ इसको पकड़ो ब्रदर.
So, in fact, Dr. Vikas is using the 4 hands, 2 from the assistant and 2 himself.
Flap पकड़ो ना. नहीं मिल रहा है. So I am still not in the correct plane. So you have to use a tooth forceps, brother. Brother, you have to use a tooth forceps. No, I am not in the correct plane. See, the perichondrium is still. पकड़ो ना brother.
Right, it's still sticking to the cartilage.
Brother, thank you. So this is still not the correct plane. So I have to get in. See, the correct plane is this. Okay, that's the correct plane.
That's right.
So if you lose the plane, so for me actually being a new setup, new instrument, new people, I am a little slow.
Yes,
please,
that's true.
Please excuse me for that. Normally,
it's perfectly fine, sir. We understand.
Knife. So now I'll tell you one very important part, how much of cartilage to keep and how much to remove. So now see, if you rotate this with your knife, आप पकड़ो खाली, उसको खींचो मत. So if you rotate this cartilage, can you see that the attachment is here?
Yes.
See, this will swing like a door. Swing door, है ना? तो ये attachment यहाँ है, इसके पीछे सक्शन करिए. इसके पीछे का पूरा हम निकाल सकते हैं. So because if you do not remove this cartilage right till here ना, ये कभी सीधा नहीं होगा. ठीक है? सेप्टम कभी सीधा नहीं होगा. तो मैं ये आगे, ये अटैचमेंट यहाँ है, इसके पीछे से मैं आगे आ गया हूँ और I can remove the whole thing.
Yeah, just anterior to the bend. You
Correct.
given the incision. Yes.
The bend means you rotate it and you will see that that's the anterior nasal spine. और ये ऊपर में जाकर के, see that's the correct plane, है ना?
Right.
Suction elevator. So unfortunately मेरे को time ज़्यादा लग रहा है, but that's the, I am trying to get the perfect plane, but see again that's not the perfect plane. This is again not the perfect plane. If you see, there is still a little bit. Can you see this perichondrium?
Yes, we can see that.
ये perichondrium पूरी निकलनी चाहिए. दो ना, कोई sharp shears दे दो ना. Sharp वाला दे दीजिए. See, that is the plane. ये वाला, है ना? ये plane है.
Yes.
Sharp वाला, correct. ये प्लेन है ना, ये प्लेन में जाएंगे ना तो एकदम ए वैस्कुलर आएगा. दैट इज द प्लेन. ठीक है? तो अगर यहां पे टाइम लग रहा है तो लग रहा है. डोंट प्रोसीड टिल यू गेट द करेक्ट प्लेन, बिकॉज देन योर होल सर्जरी इज गोइंग टू बी स्पॉइल्ड. और ऊपर जाएंगे. हाँ, ठीक है?
You cut through the mucosa if you are not in the right plane.
करेक्ट. और दूसरा क्या, ब्लीडिंग होते रहेगी. ये करेक्ट प्लेन है. ये नीचे तक नहीं आया है बिकॉज मैंने यहां गलत उठा लिया था ना. So and left side we are bound to traumatize the flap because it's convex. So right side we have to preserve the whole flap.
That's true. One side of the flap must be preserved.
Preserved.
To avoid perforation.
ठीक है? तो ये मैं पूरा उठा लेता हूं. ठीक है? दिख रहा है बराबर?
Yeah.
अभी जाकर के ये बराबर प्लेन आया.
You release the bone.
ठीक है? ये पूरा ऊपर तक और पूरा नीचे तक, ये पूरा अब एकदम बराबर आ गया. तो ये पूरा प्रिजर्व हो गया फ्लैप. अभी लेफ्ट साइड फटे नहीं फटे अपने को कोई चिंता नहीं है. ठीक है ना? ये एकदम वी हैव गॉट राइट टिल द फ्लोर ऑफ द नोज. गिव मी लक्स फॉरसेप्स नाउ. लक्स बड़ा वाला एडल्ट पेशेंट है ना. नाउ सी, आई हैव नॉट येट गॉन ऑन द लेफ्ट साइड कंप्लीटली बिकॉज आई वॉज इन द रॉन्ग प्लेन. सो पहले मैं जितनी है ना, सी दिस प्लेन वॉज रॉन्ग. तो कोई बात नहीं, अभी मैं आगे तक जाता ही नहीं हूँ बिकॉज वो प्लेन गलत था. जितना दूर तक उठाया है सिर्फ उतना निकाल देता हूँ एंड देन आई विल गेट इन टू द करेक्ट प्लेन बिफोर आई प्रोसीड फर्दर. क्यों चेंज करो ब्रदर? सेप्टोप्लास्टी करें, सेप्टोप्लास्टी सक्शन दो ना. थैंक यू. ठीक है? नाउ दैट्स द करेक्ट प्लेन एंड यू हैव टू गो रियली वेरी हाई बिकॉज नहीं जाएंगे तो ऊपर का नाक खुलेगा ही नहीं. अभी इस साइड तो फटने वाला ही है. वी आर रेडी फॉर दिस. ठीक है? जो बच गया सो बच गया. इधर तो मतलब वी आर रेडी कि फटने वाला ही है. ठीक है? लक्स. Now let's go for the higher part. Now see.
Achha, Dr. Vikas, would you not use crisscross incisions to break the internal elasticity of the cartilage?
मैं पूरा निकाल ही दे रहा हूँ ना सर. तो सर मैं तो पूरा निकाल ही दे रहा हूँ ना. तो लैक्सिटी ब्रेक करके क्या फायदा? I am removing the whole cartilage. I will only leave 3 mm, 4 mm, 2-3 mm at the top. मैंने पूरा का पूरा निकाल ही दिया ना सर. और ये बोन.
Right.
Now I'll show you. लोग इसको निकालने में इतना डरते, मैं आपको नेविगेशन पे दिखाता हूँ. ऑडियो विजुअल नेविगेशन दिखाओ भाई. सी वेयर वी आर. वी आर बिलो दी नेजल बोन इधर किधर है स्कल बेस, ठीक है सर, इसके पीछे ये तो कार्टिलेज थी, इसके पीछे ये बोन है।
Yes, that's right.
अरे नेविगेशन दिखाओ, ये आ ही नहीं रहा नेविगेशन, क्या प्रॉब्लम है? हाँ, see this part which is so high, we are still not below the skull base. Can you see that on the navigation?
Yes,
skull base यहाँ पर जा करके आएगा, यहाँ आता ही नहीं है। इधर का हम लोग हाई डेविएशन क्यों छोड़ते हैं? बिकॉज डरते हैं फालतू का। वो तो फ्रंटल के नीचे है ना, लक्स दे दीजिए, इसीलिए वो एरिया खुलता नहीं है। तो दिस इज अगेन अ वेरी वेरी इंपॉर्टेंट पॉइंट। डोंट पुल ब्रदर, डोंट पुल। नाउ दिस कार्टिलेज is below the nasal bone. छोड़ दो, आप हाथ हटा लो, हाथ हटा लो। So we have to remove this. Only leave 2 millimeters कि सुप्राटिप डिफॉर्मिटी नहीं हो जाए, 2-3 मिलीमीटर बस यहाँ छोड़ करके। See this? तो ये इंटरनल नेजल वाल्व है, तो पूरा खोल दिया हमने। ये इतना मोटा बोन जो है, दिस इज बिलो द फ्रंटल साइनस, ये भी निकाल दिया, तब जाकर के नाक खुलेगी पूरी। ये अब जाकर के इसके पीछे का जो एरिया है ना, नाउ दिस एरिया इज द एरिया बिलो द स्कल बेस। आई विल शो यू वंस अगेन। सेप्टोप्लास्टी में इतनी सारी चीजें देखिए, अभी तक स्कल बेस नहीं है, ये मोटी बोन स्कल बेस के नीचे नहीं है। कैन यू सी दैट?
Yes, we
ओनली दैट मोटी बोन I can remove very easily this thick bone. See this? So unless you remove this thick bone and this part of the cartilage, your nose is not going to, nasal valve is not going to open, and the patient is not going to perceive a, see this, how high I have gone, but only below the frontal sinus and the nasal bone. Now I will go to the area, this area, thin bone, this one is below the skull base. तो ये मोटा वाला बोन तो पहले निकाल दूं, इसमें तो कोई रिस्क नहीं है. This thick bone I am removing without any risk. ठीक है? Now nose, I'll show you the nasal cavity, how nicely it will open. This thin bone, anyway you can simply remove, because this thin bone has no power anyways. अगर कुछ लगा तो scissor use कर लीजिए. Now I'll come to the lower part. So even in septoplasty there is so much to improve, because we were not taught all these things. Lux, lux, lux. Now we can, so again doing a work completely. Once you completely do a septoplasty, then your patient will have a lifelong open nose if your diagnosis was a structural problem. And anyway this patient has to get good amount of nasal spray for life. चलिए लक्स लक्स, चलिए अभी रूटीन सक्शन. So it took us 10 minutes to do the septoplasty, but he'll have his left side of nose always open. Now let's see how much is the passage. Suction दे दीजिए, कोई अच्छा सा जाड़ा चलता हुआ. एक पैटीज दे दीजिए. Now see, now whole nose is open in front of us and it will remain like that for life. This is all polyp. Can you give me some debrider which is working? Okay. So now see, this part was not seen only. And these are some polyps arising from the septum. Very atypical case. There is some classification given to this kind of pathology. सक्शन कॉटरी रेडी रखिएगा. सक्शन कॉटरी रेडी. I'm just debriding to make some space. There's no anatomy visible right now. And you can see on navigation what I'm doing. I am not looking at that. कल के केस के लिए navigation आप चालू करके रखो, कल कोई excuse नहीं सुनूंगा.
Currently, this looks as if you are excising the anterior end of the middle turbinate on this side as well.
Yeah. I have not seen the middle turbinate so far. It is all polypoidal. I think this is the middle turbinate. This is the middle turbinate. It's all polypoidal, full of polyps. The idea is that this patient should not land up with another surgery in his lifetime. They are all polyps medial to the middle turbinate. So rising from superior turbinate, medial wall of the middle turbinate. Because of the deviated septum, I could not debride all those things before. Now let's have some. This is the skull base. I mean the wall of roof of the nostril here. Suction cautery ready. We will cauterize that first because it's going to bleed, and bleed. So we have, that's the frontal beak. So, right, that's the frontal beak on the CT scan, right?
Yes,
So वहाँ पे तो कोई नुकसान ही नहीं ना, जितना मर्जी उतना कॉटरी करें. एक सेकेंड, चलो कॉटराइज, कॉटरी अच्छे से, कॉटरी, ओके, कॉटरी, 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 तो ड्राफ्ट 3 में ये सब निकाल देते हैं, लेकिन जरूरत क्या है, यहाँ तो स्प्रे अपना पहुंचेगा ही ना सर. कॉटरी, कॉटरी,
Yes.
यहाँ तो स्प्रे पहुंच ही जाएगा, तो क्या स्टॉप.
The whole idea is to enlarge the opening and open the frontal sinus to restore the drainage and ventilation.
या और ये वाला एरिया में तो अपना बस, ये वाला एरिया में तो अपना स्प्रे पहुंच ही रहा है ना.
Right. We can straight away look into it with a 0-degree scope. Clearly look into this.
Now I'll start off with sinus surgery. Give me a patty. Now there's huge amount of space in the left nostril for the spray to go.
Right.
Patty, एक और patty. Suction cautery. So now we'll go for the sinus surgery of the left side.
Right.
Chalo, suction cautery. Now this was on the nasal septum. Can you see? So this was the area of cautery. Bas. Cautery. 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 Bas. Cautery. Bas. Now see this is the middle turbinate. ये middle turbinate की हालत देखिए ना कैसा है. ये middle turbinate है. चल.
Sir, one question is there.
Yes.
Sir, after so extensive
Divider.
debridement,
Yeah.
will the patient have problem of empty nose syndrome?
Not
following
at all.
operation?
Not at all. Inferior turbinate को कहाँ छुआ है हमने? Inferior turbinate we have not even touched. How empty nose syndrome?
Okay, sir. Thank
Yeah,
you.
see, inferior turbinate is absolutely normal with its blood supply and nerve supply. So forget about empty nose syndrome. It never happened. Now see, this was our middle turbinate. This is the polyp medial to the middle turbinate, and that's the superior turbinate. Polyp arising from the superior turbinate. So I will.
Good afternoon, sir.
Yeah.
One question, sir.
Yeah.
This is Dr. Rachin. Sir, if we have polyps in this olfactory area, so how do you?
This was the
proceed for
polyp
such
in the
a-
olfactory area. I have completely burnt it. So your olfaction was at problem, now will be at problem. He will not get his olfaction back. This guy will never get his olfaction back. I have already
Some
cauterized that.
patients have got multiple polyposis over that area, but still they have some sort of smell.
Yeah, so whatever
whether
was
it's
there,
not
it will improve, na?
Yeah.
Whatever little was there. See, I have burnt this area.
Yes, sir. Yes, sir. You can see that.
So जो बचा रहेगा वो सब बच जाएगा, लेकिन जो पहले तो पॉलिप से नहीं पहुंच पा रहा था, अभी तो हवा डायरेक्टली पहुंचेगी ना. बट मैंने एंडिंग्स तो बर्न कर दी है, इसमें कहाँ
Sir,
ऑल्फेक्शन का
but if
सवाल.
अगर ये fibrosis होता है तो
हाँ
fibrosis will occur, no, sir, if you burn the tissue over there.
हाँ, तो क्या फर्क पड़ेगा. तो ऑल्फेक्शन,
that's what I was wondering, ना,
हाँ
sir,
एकदम
whether
बराबर,
because of
ऑल्फेक्शन इसको नहीं मिलने वाला है. नाक खुली रहेगी, दैट इज इनफ.
Yes,
नाउ इसका किधर है अपना, इसका अंसनेट किधर है, मैक्सिला किधर है? कैन यू टेल मी वेयर इज द अंसनेट, वेयर इज द मैक्सिला? Anybody can tell me the anatomy here? Where should I open up the maxilla? Where is the uncinate? Aaya na maja? So now let's navigate. I'm just, see, you can always, see, this is the area of the maxillary ostium. ये अपना पूरा uncinate है. ठीक है? तो अभी सबसे पहला तो काम हम करते हैं, ये एक कर्व सक्शन दे दीजिए ना मैक्सिला में, कर्व सक्शन डालकर. अच्छा ठीक है, चलिए लेट्स स्टार्ट विथ फ्रंटल. वेयर इज द फ्रंटल हियर? नो एनाटॉमी सीन. सो दिस वाज आवर एरिया ऑफ अनसिनेट. मिडिल टर्मिनेट यहां से निकाला था ना हमने. See,
Dr. Vikas, it is advisable to do the middle turbinectomy of initial stage of surgery?
see, in this case, see, I have been doing this for many, many years. If you want to
Okay.
preserve the middle turbinate as a landmark, you please preserve it and cut at the end. I have no objection. But ये निकाल दिया ना तो फटाफट इतनी जगह मिल गई काम करने को. नहीं तो अभी तो हम लोग स्ट्रगल ही कर रहे होते. ये मिडिल टर्मिनेट का रेमनेंट है, दिखा? दिस इज द रेमनेंट ऑफ द मिडिल टर्मिनेट. तो इतना तो बचा है ना अपने. So I'm now going lateral to the middle turbinate. ठीक है?
For beginner, it is better to preserve it.
Better to preserve it. Absolutely correct. Now let me have something. कुछ बैक कटिंग वाला आपका है तो दो ना. कुछ दिखता है अगर तो दिखाते हैं. नहीं तो अदरवाइज ये अनसिनेट तो यहाँ पे हमने, या तो अनसिनेट पूरा पॉलीपॉइडल हो गया. Where is the uncinate? I cannot see anything. है ना, ये तो मिडिल टर्मिनेट का एक सक्शन कॉटरी दे दो ना, आर्टरी है. मिडिल टर्मिनेट ये था तो अनसिनेट कहाँ था?
Yeah, sometimes it's very difficult to
See, but I have not,
isolate.
see, I have not cut the uncinate. I am already in the maxilla here. So simple thing I can do is to, chalo, upward. आपके पास सक्शन कॉटरी रेडी रहेगी तो उसको टच कर देंगे.
If axilla is where you are showing, then this.
ये अभी हम लोग मैक्सिला को खोल देते हैं पूरा. नीचे जाकर के अपर अनसिनेट को निकाल देते हैं, लोअर पार्ट ऑफ अनसिनेट. अभी इतना है ना, ये लोअर पार्ट ऑफ अनसिनेट कर दिया, मैक्सिला खोल दिया पूरा. डिब्राइडर. अरे ठीक है, चलेगा, जो भी है दो ना. नाउ अभी जहां था अनसिनेट वो शायद ऑलरेडी पॉलीपॉडल होकर के अपना सैक्रिफाइस हो चुका. कोई लैंडमार्क नहीं है ना. चलिए अभी एक मेरे को सक्शन कॉटरी दो ना, मिडिल टर्मिनेट को तो सक्शन कॉटरी, ये मिडिल टर्मिनेट का एंड से जो ब्लीडर है उसको बंद करूं पहले. तो अभी इसका इथमॉइड्स भी एकदम छोटा है. वाई? बिकॉज there was a deviated septum on the left side, so the ethmoids were not grown properly. यहां पर वेसल थी मिडिल टर्मिनेट की. टच करो, टच. ब्रदर क्या नहीं चल रहा है? कॉटरी टच करना भाई. यू कीप टचिंग. चलो भाई कॉटरी ठीक है, कॉटरी जब आएगी तब बता देना, नो प्रॉब्लम. So now this is our middle terminate. Let me try to show it to you on navigation. सर ये मिडिल टर्मिनेट का रेमनेंट है, राइट? अब हम इसके लैटरली जा रहे हैं. ये अपना इथमॉइड, एंटर इथमॉइड होना चाहिए, तो मैंने इसको एंटर इथमॉइड को पूरा डिब्राइडर से ही ब्रेक कर दिया. आइडियली आई शुड बी यूजिंग Again, for beginners, don't do this. You use the right instruments, but in want of time, I am taking liberty. ये भी ब्लॉक है यार, कुछ तो दो. चलो अपवर्ड दो, जो कुछ तो दो, जो देना दो. अनफॉर्चुनेटली ना सर्जन्स में पेशेंस थोड़ा सा कम होता है. तो
नहीं डॉक्टर विकास, जो एक्सपर्ट सर्जन्स होते हैं they get little impatient, but they know what they are doing. Like
हाँ, मतलब obviously you cannot damage somebody's orbit or skull base.
So you are expert, and therefore you can take these liberties.
हाँ, that's what is that a newcomer should never take liberties to do things with the wrong instrument.
Right. That's right.
चलिए ना, कुछ मिलेगा. Because see, if you give a complication, अब कोई बचाने नहीं आएगा.
That's correct. So that is the
कोई बचाने नहीं आएगा.
Which has been opened, and that was the bulge beneath.
ये अपना आ गया ऑर्बिट, है ना? ये आ गया लैमिना पेप्रिशिया.
Yes. And the upper limit of the bulla will define the location of the anterior ethmoidal artery.
अब हम लोग जा रहे हैं. ये हमने बुल्ला पहले निकाल दिया बिकॉज यहाँ जगह ही नहीं थी. ये मिडिल टर्मिनेट है.
Yes.
नाउ फ्रॉम हियर विल गो फॉर द फ्रंटल. ये तो आ गया अपना लैमिना पेप्रिशिया, है ना? ये एंटीरियर एथमॉइडल है, वो पोस्टीरियर एथमॉइडल. तो अभी नीचे है, इसके लिए मैं बिना, आई डोंट नो वेयर आई एम. आप नेविगेशन पे देख लो मैं कहाँ पर हूँ. मैं अपने अंदाज से करते चला जा रहा हूँ.
Yes, that looks perfect. You are trying to perforate the ground lamina and going into the posterior ethmoidal cells.
बिकॉज अगर क्लासिकल वे से करते ना सर, तो ये मतलब रात के 7-8 बजे तक ये सर्जरी खत्म नहीं होने वाली थी.
So it is actually classical that you are doing, and it's very interesting at the right speed and the right structures you are.
Now where I am?
Yes.
I'm in the posterior ethmoid.
Lamina perforated and entry
posterior
into the posterior ethmoid. Yes. And we see the horizontal attachment of the middle turbinate.
ये
and
अपना
the
आ गया
vertical attachment.
left
Yes.
sphenoid. So
That's
so
right.
this is also kind of an onodi cell.
Yes.
Block.
So onodi cells in the scan, they are best visualized in the axial cuts.
ये थोड़ा दो ना divider. So sphenoid has a big large polyp at the entrance.
Yes. Yes, we
Okay.
can see that cut out.
अभी ये sphenoid already opened है ना बड़ा.
Yes, yes.
Already
very much.
wide है तो अपने को कुछ करने की जरूरत नहीं है.
It's not like easy. Only an experienced hands can work with that speed to, under the skull base, as Dr. Vikas is doing. Because the mucosa looks very unfriendly. There's a lot of oozing. So,
अभी अपना ये anterior skull base का पूरा काम बाकी है. So I'm not very happy with this situation. इसलिए मैंने पहले जो सीधा सीधा था वो कर डाला. ये निकाल देंगे. ये थोड़ा सा जो
almost done. You've just left with the frontal sinus.
हाँ बस
opening.
frontal वाला खाली काम बाकी है.
Yes.
Now see,
That will be,
so
yes.
now see this middle turbinate. If I preserve this, I cannot. Now whether this is lamina or whether
Try to use the curved section
is
to find
this
the opening
see
of frontal sinus.
is this orbit or is there any cell? Anybody? So this is orbit.
Looks like it.
Now let's see on the CT scan. This is orbit. My clinical sense says this is orbit. Anybody?
We can see in the navigation if
It's right on the orbit. Okay.
right.
perfect.
It looks like it is
हाँ,
an
तो बस-
orbit.
अब ये give me upward. ये मैं middle turbinate का जो थोड़ा सा बचा था उसको भी निकाल रहा हूँ upward.
We can use a J curate or an upward section. curved
Unfortunately, navigated upward section is not working.
Available.
Yeah.
Okay.
I only have one 12-degree blade to show navigation. So they have 4-5 instruments. None of them is working.
Okay.
So actually speaking, I am not dependent on navigation.
Right.
Because if you are dependent, then it can give you कभी भी धोखा देके जाएगा ना. लेकिन आपको हेल्प करने के लिए अच्छा है. Upward please, upward, upward.
What I tell our students, Dr. Vikas,
Yeah.
is we tell them we see the CT scan so many number of times, it takes an imprint on our mind.
Absolutely.
And your mind starts functioning like a navigation actually when you are doing endoscopy.
बट इतना ही है सर कि इतना कॉन्फिडेंटली इतना सारा काम करने में मुझे 24 साल तो लग चुके हैं अभी तक.
That's very true.
तो हाउ और अभी भी उतना कॉन्फिडेंस नहीं आता है ना हर बार. हाउ
Right,
कैन आई
right,
एक्सपेक्ट अ
right.
न्यूकमर?
Right.
Now I am pretty high and the frontal would be somewhere here.
Yes, absolutely right.
फ्रंटल यहाँ पे और आ गया है तो मैं इसको पहले पूरा निकालता हूँ. बिकॉज इसी में मिस्टेक हो गई ना. फ्रंटल यहाँ आना चाहिए. So I believe navigation is a way to go. For future generation, they will have to invest in navigation. Because रिजल्ट नहीं दिया तो भी कोर्ट केस हो जाएगा और कॉम्प्लिकेशन दिया तो हो ही जाएगा. अभी तक इंडिया में चल रहा है, नहीं हो रहा है. आने वाले टाइम में होगा. So see, that should be the area of frontal where I am actually on the CT scan. Am I in the frontal recess?
Yes, the scan shows that you are hitting at the right place.
And I should be into the frontal anytime now.
It seems you are in the open.
Right?
Yes, yes.
एक मिनट
very much.
upward for suction दीजिए ना.
Are you using the straight divider blade or the curve?
Yeah, 12 degree. Only 12 degree.
Okay, 12 degree.
Yeah. So right, see, I am already in the frontal.
Yes.
Walking
This is
into the
umbrella
frontal.
punch.
ठीक है? 70 degree here. So that's the frontal. Now this is the area behind the frontal, and somewhere here I'll get the entorethmoidal, and these all air cells I have to remove. Now when you have to remove the air cell behind the frontal and ahead of the entorethmoidal artery, that is the real area where, I mean, let me try to show it with the navigation. यहीं पे काम छूटता है. Okay, where I am now? I am pretty near the skull base. यहाँ पे skull base turn करता है ना. ठीक है, I am absolutely near the skull base. But if I leave behind air cells here, the patient will get a guaranteed recurrence.
Do you, like, are you using the 0 degree scope, it seems?
0 degree, always.
Yes. Do you prefer to use at times the 70 degree or the 30 degree?
There is a small bleeder here. Anybody can think I can get entorethmoidal artery here?
Looks like it's closely related, a little posterior. Just above where you excise the bulla ethmoidalis.
Chalo. Can you give me some curved suction? Now see this case, if you have to give a complete result, you will have to remove all the air cells. If that is the frontal recess, the skull base would be turning somewhere here. I do not have the navigation to see in that area. And the skull base I see is here. Now I am not 100% sure at this point of time, but I still do not want to leave behind disease. So what do I do? Okay, I'll just take a break for half a minute. Give me a patty,
so
please.
Would you like to pack or irrigate for some time?
That's what I'm doing.
Right.
Just give me a patty. Because this is a very, see, my job is 80, 90, say 90, 95% done. Only the last thing I want to, now the bleeding has also stopped because the disease is out. And job is complete, so by and large he will not get a recurrence, but only the last part, one air cell that may or may not be very close to the entorethmoidal, I want to check. And believe me, if you try to preserve the middle turbinate in such cases, na, काम भी नहीं होगा और preserve भी नहीं होगा. Recurrence तो guaranteed ही है. So see, this is the frontal for sure. Give me one more patty, please. So next 5 to 7 minutes and the case will be over. What is the time now?
It's 8 o'clock.
4 o'clock.
3:45, it seems.
3:45. Okay, I think we are running quite late. Suction दीजिए ना. Debrider वाला दे दीजिए.
So as far as the surgery goes well, you are never late, and I think you're doing pretty well. The dissection, the bleeding has calmed down.
Now see here, I am not 100% sure.
Yes.
About the entorethmoidal artery, and I do
So
not.
I think we can irrigate a couple of times. Maybe the things will become more clear if you find right.
Yeah. So I'll just see. This is an air cell. Okay, so I am gently breaking this air cell. I'm not debriding it. I'm gently breaking this air cell because entorethmoidal artery should be pretty high according to the CT scan. I do not want to demonstrate an anterolateral artery bleed.
Of course. Of course.
Okay, now I am pretty sure that I am in the posterior wall of the frontal and I am pretty close to the skull base, and obviously this is right behind the frontal recess, so obviously anterior model cannot come here, so I am debriding there.
You're pretty much into the frontal sinus now.
Yeah, and this air cell, you can see I have already
Yeah, you have already got rid of that.
got rid of that.
Yeah.
Now so I am not debriding directly, I am first breaking it and then debriding. Okay. So again, for newcomers, please do not debride any area near the anterothomoid artery like this, please. Okay?
Yeah, it's better not to be liberal in this area.
Yeah, take all the precautions. But see, I am right at the skull base, sir. There is
Yes,
nothing
very
here.
much. That's
Right? Can you see on the sagittal? There is no air cell left.
Right.
Okay, there is no air cell left. And most likely the antereth model will come here. So now I am pretty sure, and I can debride even this. It's a little too risky, but I am sure that I am not.
But I think it's not required. This
हाँ, even if you leave it, it's all right. But अपना मन नहीं मानता ना. सर दिल मांगे मोर है ना थोड़ा सा. अभी तो कुछ भी नहीं छोड़ा है ना. नहीं तो कल सतीश बोले अरे क्या करके छोड़ दिया. सतीश इतना बिना नेविगेशन के करता है सर. Okay.
Yes.
So nothing left. Right, sir?
Well done.
Nothing left.
Well done.
Frontal, sphenoid. Now this little bit of, that's the sphenoid.
Right.
Where is our sphenoid here? Now this little bit of air cell.
Dr. Vikas.
Sir.
The organizers have conveyed that Professor Daniel is here in the auditorium.
Yeah, you can start with his lecture. I am done. So I think my work is over.
Yes, and since you have finished the surgery.
Finished the surgery, yes.
Yes, it is been such a pleasure watching you operate.
Thank you so much.
And
Thank you.
The
So
auditorium is full of, it's full of appreciation for you. A big
Thank
round
you.
of applause.
Thank you, sir. Thank you very much.
Thank you very much for this
Thank you, sir.
demonstration.
Thank
We'll
you.
switch over to the auditorium from the OT.
Yes.
Thank you very much.
Thank you. ठीक है, अभी आप लोग क्या डालते हो पैक के लिए?
And Dr. Amol Khali sir to
हाँ.
state
नहीं तो
moderators,
नहीं मेरा
Dr.
सिल इज फाइन.
Alok
और ऊपर क्या डालते हो आप?
Priyanka Garola ma'am.
दो ना जो मिडिल में एटस के लिए तो कुछ है ही नहीं अपने पास. तो जेल फोम डालते हो, क्या डालते हो इधर ये सब एरिया के लिए? नहीं कुछ ऊपर के हाँ सर्जी सेल वगैरह कुछ दे दे सर. पेशेंट को रिजल्ट एकदम बिंदास मिलेगा. इस जिंदगी में इसको दोबारा सर्जरी नहीं लगेगी. बराबर सर, कुछ नहीं छोड़ा है. ठीक है, ये इसका पिट्यूटरी आ गया. ठीक है सर. फ्रंटल टू स्फेनॉइड विथ 0 डिग्री. हाँ मतलब इसमें सर क्या सर्जरी कोई करेगा ना दोबारा, कुछ करने को है ही नहीं. ज़्यादा से ज़्यादा डिब्राइडमेंट लोकल में.
Dr. Priyanka Garola ma'am.
दे दीजिए जेल फोम वगैरह जो देना दे दीजिए. काफ़ी सारा जेल फोम दे दीजिएगा और जो आप पैक देते हैं मेरोसेल वगैरह वो दे दीजिए. I don't think I have left anything. कितना 1.5 घंटा लग गया कि ज़्यादा लग गया? 2 घंटे लग गए सर। इतना बहुत ज़्यादा था सर। ब्लीडिंग ये नहीं चल रहा, वो नहीं चल रहा, वो नहीं चल रहा, वो नहीं चल रहा है। अगर इनका नेविगेशन भी अच्छा चलता ना और अच्छा लगता। अच्छा ये इधर एक छोटा बोन था, छोड़ देता हूँ, चलेगा। चलिए जेल फॉर्म में मिल जाएगा तो चलेगा, सर्जिकल नहीं तो छोड़ दीजिए। हाँ जो भी है रेडी हो दे दीजिए। अरे दीजिए ना, जो है सो दीजिए। जो जैसे जो है जो रेडी हो दे दीजिए फटाफट। काफी सारा जेल फोम लगेगा पूरा स्कल बेस तक ऊपर तक है। दीजिए, डाल दीजिए, सारा डाल दीजिए। ठीक है, अच्छा सलाइन में रखते हैं। आप डालोगे? अरे ये तो जा ही नहीं रहा है। डालो ना फटाफट डालो ना, काफी सारा लगेगा। मैंने इसीलिए बोला ये अपना मतलब सालों साल का एक्सटेंसिव कितना भी रहे रूटीन काम है। तो पैपुलोमा में क्या होता है कि वो अपना रोज का काम नहीं है, तो वहाँ पे आई विल नॉट बी दैट। जैसे सतीश वगैरह का वो सब ट्यूमर्स, मेरा ट्यूमर्स में इंटरेस्ट ही नहीं है, भगा देता हूँ ज़्यादातर, भेज देता हूँ अपना नारायण के पास इधर उधर, क्योंकि ट्यूमर्स का रिकरेंस ये वो झमेले वाले जो मैलिग्नेंसी ट्यूमर में उतना मज़ा ही नहीं आता है। ये सब काम एकदम एक बार कर दिया ना, अब इसको ज़िंदगी भर कुछ सर्जरी नहीं लगेगी दोबारा। हाँ पैपिलोमा मैंने किए हुए हैं, मुझे लगता है मैंने 15-20 किए होंगे। एंजियोफाइब्रोमा में वैसे ही 15-20 किए होंगे, लेकिन 24 साल में अगर आपने 15-20 कोई चीज़ की है तो कॉन्फिडेंस नहीं आता है ना सर। जो आपने हजारों हजार किया है, वो कैसा भी केस हो, कितना भी ब्लीडिंग होने दो, खाली डेमो थोड़ा खराब होता है, बट काम तो पूरा ही करके निकलेंगे। ये कैसा भी रहने दो, मतलब ये काम ऐसा करके देंगे कि भाई इसको जिंदगी में इससे अच्छा कोई काम कर नहीं सकेगा। तो इसलिए मैंने आपको बोला यही रखिए। क्या है? इसमें धागा नहीं रहता है क्या? और पानी करो। ठीक ठीक। थैंक यू। सॉरी फॉर मी बीइंग इम्पेशेंट। नहीं तो खत्म नहीं होता 2 घंटे में भी।
नहीं सर।